Hello and welcome to your ultimate guide for the HESI Pharmacology exam. My goal today is simple: give you everything you need to fully understand the key concepts, master them, and walk into your HESI Pharmacology exam with total confidence. In this video we'll cover topical absorption, dermatitis treatments, sun protection, psoriasis medications, acne therapies. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website offers free exam guides and practice questions to help you ace your HESI Pharmacology exam. You'll find the link in the description below, so be sure to check it out and get the resources you need to study smarter, not harder. So let's get started.
Question 1. A nurse is teaching a client who is beginning oral cyclophosphamide therapy for breast cancer. Which instruction would the nurse provide regarding administration of this medication? Your options are: A. Pair the dose with a small snack to reduce stomach upset. B. Take the dose with the largest meal of the day. C. Crush the tablet and mix it into a glass of juice. D. Take the medication on an empty stomach without food. Which one is it? Pause the video if you need more time. The correct answer is D. Take the medication on an empty stomach without food. D is correct because oral cyclophosphamide is administered on an empty stomach to support consistent absorption. The client should also increase fluid intake to 2 to 3 liters daily to reduce the risk of hemorrhagic cystitis and report signs of infection or bleeding promptly. A is wrong because pairing the dose with a snack alters absorption of cyclophosphamide and conflicts with the empty stomach requirement. Even small amounts of food shift the medication into a fed state and reduce predictable serum levels. B is wrong because taking the dose with a large meal contradicts the administration rule for this agent. A heavy meal pushes the medication into a prolonged fed state, which alters timing and undermines reliable home dosing. C is wrong because crushing the tablet and mixing it into juice exposes the caregiver to cytotoxic dust and is not an approved technique. Oral chemotherapy must be swallowed whole on an empty stomach to preserve formulation integrity. Oral cyclophosphamide is a nitrogen mustard alkylating agent with very specific administration rules that exist for precise pharmacokinetic and protective reasons. Understanding the why behind each rule is what makes these instructions stick. The empty stomach rule is not about comfort. It is about pharmacokinetics. Food delays gastric emptying and stretches the absorption window, making serum levels unpredictable. Because the entire chemotherapy regimen depends on a reliable time concentration curve, oncology protocols treat this as a non-negotiable requirement. Cyclophosphamide breaks down into acrolein, a toxic metabolite excreted in urine that can severely irritate the bladder lining, causing hemorrhagic cystitis. To protect the bladder, clients must drink 2 to 3 liters of fluid daily and void frequently, especially before bed, to prevent acrolein from sitting against the urothelium for extended periods. Inside the body, cyclophosphamide is a prodrug activated by the liver into a form that attaches all kill groups to the N7 position of guanine, cross-linking the DNA double helix and halting replication, rapidly dividing cells, tumors, but also bone marrow, hair follicles, and gut lining are hit hardest, which explains alopecia, neutropenia, and mucositis as predictable toxicities. 2 classic exam distractors appear with this drug. First, nausea does not justify giving cyclophosphamide with food. Scheduled antiemetics manage nausea while preserving absorption kinetics. Second, the tablet must never be crushed, as this exposes caregivers to cytotoxic dust and destroys the controlled formulation. Question 2. A nurse is teaching a client with diabetes mellitus about insulin injection site rotation at home. Which technique would the nurse instruct the client to use? Your options are A. Inject into the same spot on the abdomen each day. B. Rotate randomly between the arms, thighs, and abdomen. C. Rotate within one anatomical area before moving to the next. D. Inject into areas of scar tissue to reduce bruising. Take a second. Which answer would you pick? The correct answer is C. Rotate within one anatomical area before moving to the next. C is correct because systematic rotation within one anatomical area prevents lipodystrophy and promotes even absorption. Injection sites should be 1 to 1.5 inches apart, and the same site should not be reused for 2 to 3 weeks to maintain consistent insulin kinetics. A is wrong because repeatedly injecting into the same spot leads to lipodystrophy and unreliable absorption over time. The fatty tissue at that site becomes hardened, which slows uptake and produces unpredictable glycemic responses. B is wrong because random rotation between body areas creates inconsistent absorption rates. Each body region has a different uptake speed, so switching daily between abdomen, thigh, and arm causes erratic blood glucose patterns. D is wrong because scar tissue has reduced perfusion that delays insulin absorption unpredictably. Selecting scarred or hardened sites disrupts the systematic rotation pattern and is specifically discouraged during self-injection teaching. Insulin site rotation isn't just a vague suggestion. It's the mechanism that keeps blood sugar predictable day to day. The core principle is to rotate within one anatomical area before moving to the next, so absorption stays consistent across doses. Each body region absorbs insulin at a different speed. The abdomen absorbs fastest, the upper arm a little slower, the thighs slower still, and the buttocks slowest. Jumping between regions between doses means the same number of units hits the bloodstream on completely different timelines, producing unexplained highs and lows. Within one region, each new injection should be placed about 1 to 1.5 inches from the previous one, working through a grid until every point is used before any spot is reused. This prevents injecting into previously injured tissue while keeping absorption consistent. Lipodystrophy occurs when the same spot is used repeatedly. The tissue becomes either hypertrophic, a raised lump, or atrophic, a sunken pocket. Both forms alter local perfusion, making a site that felt easy to use the least reliable place to deliver insulin. The classic exam trap is random rotation across all regions. It sounds thorough, but creates the variable absorption systematic rotation is designed to prevent. When a STEM describes unexplained blood sugar swings on a stable regimen, think uneven rotation or a hypertrophied site, not a dose change. Question 3. A nurse is teaching a client receiving methotrexate and fluorouracil about outdoor activity precautions. Which instruction would the nurse include? Your options are A. Apply sunscreen and wear protective clothing while outdoors. B. Restrict fluid intake during periods of sun exposure. C. Avoid all outdoor activity until therapy is completed. D. Withhold the medication on days with bright sunlight. Before I reveal it, which one do you think is right? The correct answer is A. Apply sunscreen and wear protective clothing while outdoors. Is correct because methotrexate and fluorouracil cause photosensitivity reactions, so the client must apply sunscreen and wear protective clothing while outdoors. Skin protection allows reasonable activity while preventing severe sunburn reactions that could disrupt the prescribed chemotherapy course. B is wrong because restricting fluids would worsen renal clearance of antimetabolites and increase nephrotoxicity risk. 2,000 milliliters of daily fluid intake is encouraged during therapy to maintain renal function, not limited during outdoor periods. C is wrong because complete avoidance of the outdoors is unnecessary and impractical. Adequate skin protection through sunscreen and clothing permits typical daily activities without exposing the client to harmful ultraviolet skin reactions. D is wrong because withholding scheduled chemotherapy interrupts the planned treatment cycle and reduces therapeutic effect. Photosensitivity is prevented through topical skin protection rather than by self-discontinuing prescribed anti-neoplastic medications. When clients are receiving cytotoxic agents like methotrexate or fluorouracil, their skin becomes unusually vulnerable to ultraviolet radiation. Even brief ordinary sun exposure can trigger an exaggerated burn. This is photosensitivity, and the key principle is that protection must be in place before going outside, not applied after a reaction develops. Both drugs interfere with rapidly dividing cells, and the epidermis is one of the fastest turning over tissues in the body. As keratinocytes are stressed, the skin's normal repair response to UV damage is blunted. Fluorouracil also directly absorbs ultraviolet energy, triggering phototoxic inflammation even at low light intensities, resulting in redness, blistering, and prolonged hyperpigmentation. Protection must be layered. The chemical barrier is a broad-spectrum, high SPF sunscreen reapplied every 2 hours. The physical barrier is lightweight long sleeves, a wide-brimmed hat, and UV-blocking sunglasses. Avoiding midday sun adds a behavioral layer. Together, these 3 precautions address the underlying problem directly. Exam distractors often suggest restricting fluid intake or withholding the chemotherapy dose on bright days. Both are wrong. Fluid restriction undermines the hydration needed to protect the kidneys, and altering the dose schedule corrupts disease control without fixing photosensitivity at all. Outdoor activity itself is not banned. It just requires the right protective routine beforehand. This protective routine is not unique to chemotherapy. Tetracyclines, fluoroquinolones, and any drug with a documented photosensitizing effect call for the same response: broad-spectrum sunscreen, protective clothing, and avoidance of peak sun. Once you learn it for one agent, it carries over to every other. Question 4. A nurse is caring for a client with burns receiving topical mafenide acetate. Several hours after application, the client begins breathing rapidly with deep respirations. Which condition would the nurse suspect? Your options are: A. Localized pain at the burn site. B. Allergic reaction to the dressing. C. Onset of hypovolemic shock. D. Systemic metabolic acidosis. What's your answer? Commit to one before I continue. The correct answer is D. Systemic metabolic acidosis. D is correct because mafenide acetate is a carbonic anhydrase inhibitor that may cause systemic metabolic acidosis, producing compensatory hyperventilation. The nurse would notify the prescriber, and the medication is typically washed off and discontinued for 1 to 2 days to allow acid-base balance to recover. A is wrong because pain at a burn site causes restlessness, grimacing, and elevated heart rate rather than deep, rapid, Kussmaul-like respirations. Hyperventilation in this scenario reflects an acid-base disturbance, not localized discomfort. B is wrong because an allergic response typically presents with rash, urticaria, wheezing, or itching rather than deep, regular respirations. Mafenide acetate specifically causes metabolic acidosis with respiratory compensation through hyperventilation. C is wrong because hypovolemic shock manifests with tachycardia, hypotension, cool clammy skin, and altered mental status long before hyperventilation becomes prominent. The breathing pattern here points toward metabolic acidosis from the medication. Mafenide acetate is a topical agent used on partial and full thickness burns, but it carries a systemic side effect that surprises many nurses. It can cause a true metabolic acidosis, even though it is only applied to the skin. Burned skin has lost its barrier function, so mafenide is absorbed in much higher amounts than from intact skin. Once in the bloodstream, it inhibits carbonic anhydrase in the proximal tubule, blocking bicarbonate reabsorption and causing bicarbonate to spill into the urine. Serum bicarbonate falls, and that falling bicarbonate is the definition of metabolic acidosis. The body compensates by increasing the rate and depth of breathing to blow off carbon dioxide and nudge the pH back toward normal. This deep, rapid breathing pattern, sometimes called Kussmaul respirations, is the bedside clue that a metabolic acidosis is underway. The key confusable is silver sulfadiazine, the other white cream used on burn wounds. Silver sulfadiazine does not cause this acid-base problem. Its concerns are transient leukopenia and sulfur hypersensitivity. When you see mafenide on the exam, think carbonic anhydrase inhibition and metabolic acidosis. When you see silver sulfadiazine, think sulfur reactions. On the exam, the signal is mafenide application followed hours later by deep, rapid breathing. The correct interpretation is compensatory hyperventilation for metabolic acidosis, not anxiety, not respiratory infection, and not a primary respiratory event. Question 5. A client with squamous cell carcinoma of the larynx is beginning intravenous bleomycin therapy. Which baseline diagnostic study would the nurse anticipate the provider to prescribe? Your options are A. Pulmonary function studies, B. 12-lead electrocardiography, C. Cervical spine radiography, D. Echocardiography with ejection fraction. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Pulmonary function studies. A is correct because bleomycin can cause interstitial pneumonitis that progresses to pulmonary fibrosis. Baseline pulmonary function studies establish lung capacity for trending throughout therapy, so early decline can be detected, prompting discontinuation before irreversible fibrosis develops. B is wrong because electrocardiography evaluates cardiac rhythm and is the baseline study for cardiotoxic agents such as doxorubicin or daunorubicin. Bleomycin toxicity targets the lungs, so a cardiac tracing would miss the priority adverse effect. C is wrong because cervical radiography images bony structures of the neck rather than alveolar function. Bleomycin's signature toxicity is interstitial pneumonitis that progresses to fibrosis, which cervical spine films cannot detect or follow. D is wrong because echocardiography measures ventricular ejection fraction and is appropriate before anthracycline therapy. Bleomycin does not cause cardiomyopathy, so a cardiac imaging study would not capture the drug's pulmonary toxicity profile. Bleomycin is a powerful anti-tumor antibiotic, but its signature danger is in the lungs. Understanding why the lungs are so vulnerable and how we monitor for damage is the core principle behind baseline pulmonary function testing before therapy begins. Bleomycin binds DNA and causes strand breaks through a free radical pathway that depends on molecular oxygen. Lung tissue is oxygen-rich and critically lacks bleomycin hydrolase, the enzyme other tissues use to inactivate the drug. This makes the lungs uniquely vulnerable, leading to inflammation and then irreversible interstitial fibrosis. Several factors dramatically raise the risk of clinically significant fibrosis. Cumulative doses above 400 units, older age, prior chest irradiation, supplemental oxygen exposure, underlying lung disease, and high inspired oxygen during later procedures all compound the danger. Pulmonary function testing includes spirometry, lung volumes, and diffusing capacity for carbon monoxide. The diffusing capacity is the earliest marker to decline in bleomycin toxicity because the alveolar wall thickens before symptoms appear. Catching a falling diffusing capacity early can prevent progression to fixed, irreversible fibrosis, but only if a baseline value exists for comparison. Each chemotherapy agent has its own signature toxicity, and the baseline test follows the toxicity. Bleomycin pairs with pulmonary function tests, doxorubicin with cardiac imaging, cisplatin with renal function and hearing, and vincristine with a neurologic baseline. Memorizing these pairings is what makes baseline questions on the exam fast and reliable. Question 6. A nurse receives a verbal medication order from a covering physician during rounds. Which missing element would require the nurse to clarify the order before administration? Your options are A. Color of the prescribed tablet, B. Manufacturer of the product, C. Date the reference textbook was published, D. Frequency of administration. Which would you go with? Lock it in before the reveal. The correct answer is D. Frequency of administration. D is correct because frequency is a required element of every prescription, along with the client name, date, drug, dose, route, and prescriber signature. A missing frequency leaves the dosing schedule ambiguous, so the nurse must clarify before administering any portion of the medication. A is wrong because tablet color varies by manufacturer and is not a prescription element. The nurse verifies the generic name on the label rather than the visual appearance, so a missing color description does not warrant clarification. B is wrong because the manufacturer name appears on dispensing labels and pharmacy records but is not part of a valid medication order. The nurse can safely proceed when the ordering details are complete, regardless of brand source. C is wrong because publication dates of reference textbooks have no role in prescription validity. Required elements concern the client, drug, dose, route, frequency, and signature rather than educational source materials. Every medication order, written or verbal, must contain the same required elements. Missing even one element makes the order incomplete, and the nurse must clarify with the prescriber before acting. The required elements are the client's full name and identifier, the date and time, the drug name, dose, and route, the frequency, and the prescriber's name with credentials. Verbal orders are held to exactly the same standard as written ones. Frequency is the element most tested because it is the most clinically dangerous when missing. Without it, the same drug and dose can produce a subtherapeutic effect, or a toxic dose, depending entirely on how often it is given over 24 hours. Verbal orders carry extra risk from sound-alike names, background noise, and accents. The readback protocol requires the nurse to repeat the order word for word, including spelling of drug names and numeric dose values, before the prescriber confirms. This is also the moment a missing frequency becomes obvious. Whether the order is STAT, standing, or PRN, a form of frequency is always required. STAT needs single dose intent and a timestamp. Standing needs frequency and hold parameters. PRN needs a maximum frequency and ceiling dose. In every subtype, frequency or its functional equivalent must be explicitly stated. Question 7. A client older than 60 years on chronic glucocorticoid therapy is starting a fluoroquinolone for a respiratory infection. Which adverse effect would the nurse instruct the client to report immediately? Your options are A. A new slow developing dry cough, B. Mild headache occurring during therapy, C. Tendon pain, especially in the Achilles area, D. Brief episodes of dizziness on standing. Don't overthink it. Which one feels right? The correct answer is C. Tendon pain, especially in the Achilles area. C is correct because fluoroquinolones increase the risk of tendinitis and tendon rupture, particularly the Achilles tendon, In clients older than 60, those on corticosteroids, and transplant recipients, the nurse teaches the client to report new tendon pain immediately so the medication can be stopped before rupture. A is wrong because a new cough is not the priority risk that fluoroquinolones produce in older adults. Tendon injury is the specific concern this drug class carries, and respiratory symptoms would not signal the imminent musculoskeletal complication. B is wrong because mild headache is a non-specific complaint common to many medications and does not capture the tendon rupture risk of fluoroquinolones. Teaching focuses on the musculoskeletal precursor symptom rather than general discomfort. D is wrong because brief positional dizziness reflects mild orthostatic changes seen with many drugs and does not signal the tendon injury that defines fluoroquinolone risk. The priority warning targets Achilles tendon pain in this client profile. Fluoroquinolones like levofloxacin and ciprofloxacin carry a serious warning that goes beyond typical antibiotic side effects. They can damage tendons, sometimes causing complete rupture. This risk is not rare or theoretical, it is well documented and testable. Risk climbs sharply when multiple factors converge. Aging tendons already have reduced vascularity and slower collagen repair. Glucocorticoids independently suppress collagen synthesis. Adding a fluoroquinolone creates three-layered stresses on the same tissue, dropping the failure threshold dramatically. At the tissue level, fluoroquinolones interfere with extracellular matrix synthesis by disrupting type 1 collagen organization and generating oxidative stress inside tenocytes. The tendon becomes mechanically weaker, or waxates dead. An activity that would normally cause only mild soreness can escalate to partial or complete rupture, sometimes within just days of starting the drug. The Achilles tendon is the most frequently affected site, but the rotator cuff, biceps, and patellar tendon can all be involved. Any tendon pain, especially heel pain, during fluoroquinolone therapy must be treated as a warning signal. Clients must be taught to stop the fluoroquinolone immediately at the first sign of tendon pain, swelling, or a sudden pop, and to rest the limb until evaluated. Acting in that early window, before catastrophic rupture, can prevent permanent injury entirely. Question 8. A nurse picks up a reconstituted multi-dose vial prepared by another nurse earlier in the shift. Which post-reconstitution detail on the label is essential for accurate bedside dose calculation? Your options are A. Strength per volume of the reconstituted solution. B. Total powder weight before dissolving. C. Expiration date of the original dry powder. D. Original price per unit charged by pharmacy. Got a guess? Lock it in. The correct answer is A. Strength per volume of the reconstituted solution. A is correct because the post-reconstitution concentration, expressed as strength per volume, is the only figure that allows accurate calculation of the milliliters needed to deliver the prescribed dose. The nurse who reconstitutes the medication must label the vial with this value for any subsequent user. B is wrong because the total dry powder weight does not translate directly into a volume after reconstitution. The downstream nurse needs the final liquid concentration, not the manufacturer's premixing weight, to compute the dose to withdraw. C is wrong because the original dry powder expiration is replaced by a shorter beyond use date once the medication is dissolved. Relying on the original date risks drawing from a degraded solution that no longer delivers the intended therapeutic effect. D is wrong because pharmacy pricing has no clinical role in dose preparation. The bedside label communicates information necessary for safe administration, such as drug, concentration, and beyond use date rather than acquisition cost. When a powdered drug is reconstituted, a new concentration is created that didn't exist before. Understanding what goes on that post-reconstitution label and why is the key to safe dose calculation. The original vial contains a fixed amount of powdered drug, say 500 milligrams. Once the nurse adds a specific volume of diluent, that powder becomes a solution with a brand new strength per milliliter. That concentration, 125 milligrams per milliliter, is what drives every subsequent dose calculation. 4 elements must appear on the updated label: the post-reconstitution concentration, the date and time, the expiration interval, and the preparer's initials with storage instructions. All are required, but only the strength per volume is the number the next nurse plugs into the dose calculation. The math is straightforward. Target dose divided by post-reconstitution concentration equals the volume to draw. If that concentration is missing or misread, the calculation has no reliable input, and the error can be tenfold or hundredfold. Expiration dates and initials matter, but they cannot substitute for that number. On the exam, when you see reconstitution or multi-dose vial, the testing point is almost always identifying the post-reconstitution concentration as the most critical label element. Dates and initials are required, but they don't tell the next nurse how much to draw. Question 9. A client has been using an over-the-counter nasal decongestant spray several times daily for 1 week and now reports worsening nasal congestion. Which condition would the nurse suspect? Your options are A. Acute worsening of the original infection. B. Newly developed allergic rhinitis. C. Reduced potency of the expired spray. D. Rebound congestion from prolonged use. Which one is it? Pause the video if you need more time. The correct answer is D. Rebound congestion from prolonged use. D is correct because topical nasal decongestants produce tolerance and rebound congestion when used longer than 48 to 72 hours. The nurse would instruct the client to wean off the spray 1 nostril at a time and limit future use to brief courses to prevent recurrence. A is wrong because a worsening infection typically presents with fever, purulent drainage, and facial pain rather than progressive congestion linked to continued spray use. The temporal pattern points to medication tolerance rather than acute infection. B is wrong because allergic rhinitis presents with clear watery drainage, sneezing, and itching rather than worsening congestion tied to overuse of a decongestant spray. The clinical pattern matches rebound effects from the medication itself. C is wrong because spray potency is a manufacturing concept and does not explain the progressive worsening that develops with repeated daily use. Reduced effectiveness in this scenario reflects mucosal adaptation to prolonged decongestant exposure. Rinitis medicamentosa, or rebound congestion, is what happens when a short-term nasal spray becomes a long-term habit. Understanding the mechanism explains both why it happens and how to break the cycle. Oxymetazoline and similar sprays work by stimulating alpha-1 adrenergic receptors, causing the nasal blood vessels to constrict. With continuous use beyond 3 to 5 days, those receptors downregulate. They become less responsive. And when the drug wears off, vasodilation rebounds harder than the original congestion. This creates a self-reinforcing loop. Each application provides shorter, shallower relief, while the underlying congestion intensifies, driving the patient to spray more frequently. The medication itself is now generating the symptom it was meant to treat. Management centers on stopping the offending spray entirely. Saline rinses and humidification ease discomfort during recovery. A short course of intranasal corticosteroids or oral pseudoephedrine can bridge the gap. Receptor populations reset on their own within days, and the congestion fully resolves. The key diagnostic clue is always the medication history. Worsening congestion after a week of daily spray use points to rebound, not a new infection or sinusitis. Recognizing that pattern and stopping the spray is the entire teaching point. Question 10. A nurse is teaching a client on long-term thiazide diuretic therapy about dietary changes. Which instruction would the nurse include? Your options are A. Reduce dietary potassium to the minimum tolerable. B. Drink only water between scheduled meals. C. Include potassium-rich fruits and vegetables daily. D. Avoid all leafy green vegetables in the diet. Take a second. Which answer would you pick? The correct answer is C. Include potassium-rich fruits and vegetables daily. C is correct because thiazide diuretics promote urinary potassium loss, so the nurse instructs the client to consume potassium-rich fruits, vegetables, and potatoes. Adequate dietary potassium reduces the risk of hypokalemia and supports cardiac stability throughout ongoing thiazide therapy. A is wrong because reducing dietary potassium would worsen the hypokalemia already promoted by the diuretic. The teaching aims to replace the renal potassium losses rather than to deepen the deficit through dietary restriction. B is wrong because restricting intake to water alone fails to address the specific electrolyte issue. Hydration alone does not replace potassium lost in urine, so targeted dietary potassium remains the correct teaching point. D is wrong because eliminating leafy greens removes one of the major dietary sources of potassium the client needs. Inclusion of these vegetables compensates for renal potassium losses during thiazide therapy rather than worsens them. Thiazide diuretics work by blocking sodium reabsorption in the distal convoluted tubule, but that same mechanism drives a predictable loss of potassium into the urine. Understanding why potassium is lost and how to prevent it is the core of thiazide discharge teaching. Thiazides block sodium reabsorption in the distal convoluted tubule. The excess sodium then floods the collecting duct, where cells exchange sodium for potassium, pumping potassium out into the urine. Over weeks of daily dosing, this loss accumulates into clinically significant hypokalemia. Clients should be taught to report muscle weakness, leg cramps, fatigue, and cardiac changes such as U waves or arrhythmias. Vane pasa, all signs that serum potassium has dropped to a clinically dangerous level. The standard discharge teaching is dietary. Encourage 3 to 4 daily servings of potassium-rich foods including bananas, oranges, avocados, potatoes, spinach, and beans. Supplements are only added when serum levels indicate need. Diet comes first. The key exam distinction is that potassium-sparing diuretics, or TSAG, spironolactone, or miloride, triamterene, cause potassium retention, not loss. Clients on those agents must limit potassium-rich foods to avoid hyperkalemia. Holding these two categories apart makes the correct dietary answer reliable. Question 11. A pharmacist explains that potassium is supplied in milliequivalents and regular insulin is supplied in units. Which statement best explains why these drugs use these designations? Your options are A. Both designations are simply milligram equivalents. B. The designations express the biological activity of the drug. C. Both medications are exempt from the metric system. D. The designations indicate that both drugs are supplied as solids. Before I reveal it, which one do you think is right? The correct answer is B. The designations express the biological activity of the drug. B is correct because a unit expresses a drug by its biological action rather than by weight. Insulin and heparin are dosed this way because their therapeutic effect, not their mass, determines administration. So converting the dose to milligrams would lose clinical meaning and create dangerous errors. A is wrong because units and milliequivalents are not interchangeable with milligrams. The labeling explicitly signals that mass-based conversion would misrepresent the therapeutic dose, since the active value reflects biological activity rather than weight. C is wrong because neither potassium nor insulin is exempt from metric measurement. Both are still delivered in metric volumes such as milliliters. Only the active drug strength is expressed using an activity-based unit. D is wrong because unit-based labeling has no relationship to physical form. Insulin is liquid in a syringe, and potassium for intravenous use is dissolved in solution. So the designation reflects activity rather than solid form. Some drugs can't be reliably dosed by weight alone, because their clinical effect depends on biological activity. Milliequivalents and units are the designations pharmacology uses to capture that activity directly. A milliequivalent expresses the electrochemical combining power of an ion, how much charge it carries in solution. A unit expresses how much biological activity a preparation produces in a standardized assay. Both are calibrated to function, not to grams of substance in the vial. Potassium chloride is the classic milliequivalent example. Cardiac muscle responds to ionic charge, not to the specific salt form. Insulin is the classic unit example. Lispro, aspart, glargine, and regular insulin all have different molecular weights, but 1 unit of each lowers blood glucose by a similar amount because the unit is tied to function. It's easy to blur these 4 terms. Milliequivalents and millimoles are related but not identical. For monovalent ions like potassium and sodium, they are numerically the same. But for divalent ions like calcium and magnesium, 1 millimole equals 2 milliequivalents. The most common test trap is treating milliequivalents or units as volume or weight measurements. They are neither. When a question asks why these designations exist, the answer is always the biological activity principle. Dosing by what the drug does, not by how much it weighs. Question 12. A client receiving intravenous unfractionated heparin develops dark urine and an oozing nosebleed. Which medication would the nurse anticipate the provider to prescribe? Your options are A. Protamine sulfate, B. Phytonadione, C. Aminocaproic acid, D. Ascorbic acid. What's your answer? Commit to one before I continue. The correct answer is A. Protamine sulfate. A is correct because protamine sulfate is the antidote for unfractionated heparin overdose. It binds heparin to neutralize the anticoagulant effect. So the nurse holds the infusion and prepares to administer protamine while monitoring closely for further bleeding or circulatory compromise. B is wrong because phytonadione is vitamin K and reverses warfarin, not heparin. Warfarin blocks vitamin K-dependent clotting factors, so vitamin K corrects its effect, while heparin requires a direct binding agent for neutralization. C is wrong because aminocaproic acid reverses thrombolytic medications such as alteplase by blocking fibrinolysis. It does not bind heparin or counteract heparin-induced bleeding, so it is not the indicated reversal agent in this scenario. D is wrong because ascorbic acid has no effect on coagulation reversal. Vitamin C plays no role in anticoagulant antidote therapy, so administering it would leave the client unprotected against ongoing heparin-induced bleeding. When a patient on heparin develops signs of bleeding, the specific antidote is protamine sulfate. This pairing is one of the most clear-cut drug-antidote relationships in all of pharmacology. Heparin carries a strong negative charge and protamine carries a strong positive charge. The 2 molecules bind rapidly in plasma to form an inert complex that has no anticoagulant activity, stopping the bleeding tendency. Clinically, signs prompting reversal include dark urine from hematuria and oozing nosebleed. bleeding at IV sites, and laboratory findings such as a markedly prolonged activated partial thromboplastin time. Protamine is dosed at roughly 1 mg per 100 units of heparin given in the prior few hours, adjusted downward over time as heparin's short half-life reduces what remains. It must be given slowly intravenously to avoid hypotension, bradycardia, and dyspnea, and patients with fish allergy or prior protimin exposure face a higher risk of hypersensitivity. The key exam trap is matching the right antidote to the right drug. Protan reverses heparin only. Warfarin requires vitamin K or prothrombin complex concentrate. Dabigatran is reversed by rituximab, and the factor XR inhibitors apixaban and rivaroxaban are reversed by andexanet alpha. Question 13. A nurse is caring for a client with HIV and pneumocystis pneumonia who is receiving pentamidine and develops a temperature of 101 degrees Fahrenheit. Which interpretation by the nurse is most appropriate? Your options are: A. The dose of medication is too low. B. The medication is producing toxic effects. C. The client cannot maintain thermoregulation. D. A new infection has developed from leukopenia. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. A new infection has developed from leukopenia. D is correct because common adverse effects of pentamidine include leukopenia, thrombocytopenia, and anemia. A new fever in a leukopenic client with HIV most likely indicates a new opportunistic infection, so the nurse monitors closely for infection signs throughout therapy. A is wrong because a low dose typically presents as treatment failure or rising organism burden rather than an isolated fever spike. The fever in this client reflects infection arising from drug-induced leukopenia rather than insufficient dosing. B is wrong because direct pentamidine toxicity manifests as leukopenia, anemia, and thrombocytopenia rather than as fever. The fever develops secondarily when leukopenia opens the door to infection, so infection is the immediate explanation. C is wrong because impaired thermoregulation is not the likely explanation in a client with known leukopenia and advanced immunosuppression. Fever in this clinical setting signals an emerging infection rather than autonomic temperature dysfunction. When a client with HIV on pentamidine for pneumocystis pneumonia develops a new fever, the most important underlying mechanism to understand is drug-induced leukopenia. Pentamidine suppresses the bone marrow directly, and an already immunocompromised host is especially vulnerable to secondary infections when neutrophil counts fall. Pentamidine exerts direct toxicity on bone marrow precursors and may interfere with folate metabolism in rapidly dividing cells. The result is a falling absolute neutrophil count, which removes the first line of defense against bacterial and fungal pathogens and opens the door to opportunistic infections. Because the immune system is doubly compromised, the workup for a new fever must be broad. Common sources include line infections, oral or esophageal candidiasis, a new pneumonia distinct from the original, urinary tract infection, and cytomegalovirus reactivation. Blood cultures, urinalysis, and imaging are all part of the initial assessment. The immediate clinical response involves 3 steps. Obtain a CBC with differential to assess the neutrophil trajectory. Start empirical antibiotic coverage while cultures are pending, and hold or switch pentamidine, noting that the alternative agent, trimethoprimsulfamethoxazole, also carries hematologic risks including marrow suppression and megaloblastic anemia. The exam trap is attributing the fever to treatment failure or hypersensitivity. Hypersensitivity typically presents earlier with rash, hypotension, or bronchospasm, not isolated fever. When pentamidine, HIV, and a new fever align, Leukopenia-mediated secondary infection is the most likely and most testable interpretation. Question 14. A nurse is teaching a client about silver sulfadiazine cream prescribed for a partial thickness burn. Which statement by the client indicates a need for further teaching? Your options are: A. The cream is an antibacterial agent. B. I will apply the cream directly to the wound. C. The cream will sting each time I apply it. D. The cream will help the burn heal. Which would you go with? Lock it in before the reveal. The correct answer is C. The cream will sting each time I apply it. C is correct because silver sulfadiazine does not produce stinging when applied to a burn wound, so this statement reflects a misconception. The cream is a broad-spectrum antibacterial applied directly to the wound surface to prevent infection and support healing of partial thickness burns. A is wrong because describing silver sulfadiazine as an antibacterial agent reflects accurate understanding. The medication has broad activity against gram-positive and gram-negative organisms as well as yeasts, so this statement requires no further teaching. B is wrong because applying the cream directly to the wound is the proper technique. Silver sulfadiazine works at the burn surface to prevent bacterial colonization and sepsis, so this statement demonstrates correct understanding. D is wrong because the cream does support burn healing by preventing bacterial infection that would otherwise delay tissue repair. This statement reflects accurate knowledge of the medication's role and does not need correction. Silver sulfadiazine is a topical antimicrobial cream applied to partial thickness burns to control bacterial colonization. Understanding how it works now and what it should and should not feel like is the core of patient teaching. The cream works through two mechanisms at once. Silver ions released from the cream disrupt bacterial cell membranes and bind to DNA. The sulfadiazine component independently blocks folate synthesis, giving broad coverage across the gram-positive, gram-negative, and Pseudomonas pathogens that commonly colonize burn wounds. Application technique matters for effectiveness. A layer roughly 1/16 of an inch thick is spread over the entire wound bed with a sterile gloved hand or tongue depressor. Old cream and exudate are removed with sterile saline before each reapplication, which occurs once or twice daily. Occlusive dressing is not required. Gauze placed loosely over the area is sufficient. Clients should expect a sensation of coolness from the cream and possibly mild tightness as the dressing settles. Stinging each time the cream is applied is not expected, and reporting that is a gap in teaching. Burning on application is actually the signature of muffinide acetate, the other topical burn agent, not silver sulfadiazine. The classic exam trap is confusing silver sulfadiazine with muffinide acetate. Muffinide penetrates eschar better but causes a painful burning sensation. Silver sulfadiazine is comfortable on the wound bed. When a client says the cream stings every time, that reveals a misunderstanding or suggests the cream is reaching healing skin where new sensation has returned. Question 15. A nurse is caring for a post-renal transplant client taking cyclosporine who reports a new headache. Which vital sign would the nurse expect to be elevated? Your options are: A. Pulse rate rising rapidly. B. Blood pressure rising above baseline. C. Pulse oximetry decreased below baseline. D. Respiratory rate rising significantly. Don't overthink it. Which one feels right? The correct answer is B. Blood pressure rising above baseline. B is correct because cyclosporine commonly causes hypertension. So when the client reports a headache, blood pressure is the priority vital sign to monitor. Other adverse effects of this immunosuppressant include infection, nephrotoxicity, and hirsutism during continued therapy. A is wrong because tachycardia is not the characteristic cyclosporine adverse effect, The drug specifically produces hypertension and renal vasoconstriction, so the nurse focuses on blood pressure rather than heart rate when the client reports a headache. C is wrong because A, falling oxygen saturation reflects a pulmonary problem rather than the cardiovascular effects of cyclosporine. A decreased reading would not explain a new headache or match the hypertensive pattern this drug typically produces. D is wrong because A, rising respiratory rate points toward anxiety or pulmonary pathology rather than a cyclosporine effect. The headache in this client most directly correlates with elevated blood pressure rather than changes in breathing pattern. Cyclosporine is a calcineurin inhibitor used to prevent rejection after solid organ transplants. Beyond its well-known nephrotoxicity, its most clinically important adverse effect is hypertension, and understanding why helps you act on the right clues at the bedside. Cyclosporine raises blood pressure through 4 independent mechanisms. It constricts afferent arterioles, activates the renin-angiotensin system, increases endothelin production, and reduces nitric oxide availability. Each of these changes drives vasoconstriction on its own. Combined, they produce a clinically significant rise in blood pressure within weeks of starting therapy. When a post-transplant client on cyclosporine reports a new headache, the first nursing action is to obtain a blood pressure measurement and compare it to the client's baseline trend. A rise above the usual range points directly to cyclosporine-mediated hypertension, rather than a primary headache disorder. Both cyclosporine and tacrolimus are calcineurin inhibitors that share nephrotoxicity, but their side effect profiles diverge. Cyclosporine is more strongly linked to hypertension, gum hyperplasia, and hirsutism, while tacrolimus carries greater risk of neurotoxicity and glucose intolerance. Keeping these two agents straight is a key exam skill. On the exam, when you see cyclosporine, post-transplant status, and a new headache in the same question, the testing point is always the expected blood pressure rise. Check the pressure first. Chronic elevations accelerate allograft injury and shorten graft survival. Question 16. A client newly prescribed a meiotic medication for glaucoma asks how the medication works. Which response by the nurse is most accurate? Your options are: A. It constricts the pupil to lower intraocular pressure. B. It dilates the eye to lessen pressure within it. C. It relaxes ocular muscles to produce clearer vision. D. It paralyzes the eye muscle to block pressure signals. Got a guess? Lock it in. The correct answer is A. It constricts the pupil to lower intraocular pressure. A is correct because meiotics produce pupillary constriction and contract the ciliary muscle, which widens the trabecular meshwork. This action improves outflow of aqueous humor, lowers intraocular pressure, and reduces retinal damage and vision loss associated with glaucoma. B is wrong because pupillary dilation describes mydriatics, which raise intraocular pressure and are contraindicated in glaucoma. Telling the client the drug dilates the eye would misrepresent meiotic therapy and could promote unsafe expectations. C is wrong because ocular muscle relaxation describes cycloplegic action used during eye examinations rather than glaucoma management. The mechanism described here does not match the constricting effect that meiotics produce on the pupil. D is wrong because anticholinergic paralysis of the iris produces mydriasis and cycloplegia, both contraindicated in glaucoma. Meiotic action is constriction of the pupil, not blockade, so this explanation reverses the actual mechanism. Meiotic medications lower intraocular pressure not by reducing aqueous humor production, but by improving how easily that fluid drains out of the eye. Understanding the anatomy of the drainage angle makes this mechanism click. The trabecular meshwork sits at the angle where the iris meets the cornea. When the pupil dilates, the iris crowds that angle and slows drainage. when a miotic constricts the pupil. The iris pulls away, the meshwork opens, and aqueous humor flows out freely, dropping pressure. The two primary miotics are pilocarpine and carbachol. Both act directly on the iris sphincter and ciliary muscle as parasympathomimetics. Their pressure-lowering effect comes entirely from improved outflow, not from reducing the amount of aqueous humor the eye makes. Because meiosis is not selective, clients lose light entering the eye and may experience dim vision at night, so caution about driving after dark is essential. Brow ache from ciliary muscle contraction is common early but tends to ease. Pressing the inner corner of the eye after instilling the drop limits systemic parasympathetic effects like nausea or bradycardia. The core principle is purely mechanical. A constricted pupil pulls the iris away from the drainage angle. The trabecular meshwork opens, aqueous humor exits more freely, and intraocular pressure falls, protecting the optic nerve from damage. Question 17. A nurse is preparing to instill prescribed eardrops for an adult client with otitis externa. Which technique would the nurse use to straighten the ear canal? Your options are A. Pull the pinner downward and back. B. Push the tragus inward firmly. C. Stretch the earlobe straight downward. D. Pull the pinner upward and back. Which one is it? Pause the video if you need more time. The correct answer is D. Pull the pinner upward and back. D is correct because for an adult, the nurse pulls the pinner upward and back to straighten the external auditory canal so the drops can travel inward. After installation, the head remains tilted while the head is gently moved back and forth to distribute the medication. A is wrong because downward and back is the technique used for infants and children younger than 3 years, whose ear canal anatomy is shorter and angled differently. Using this pediatric technique on an adult misdirects the drops. B is wrong because pressing the tragus inward does not straighten the ear canal and may push cerumen deeper. Drop installation requires manipulation of the pinner to align the canal, not pressure on the tragus. C is wrong because stretching the earlobe downward does not align the adult external auditory canal. The correct adult technique lifts the pinner upward and posteriorly to open the canal so drops can reach the tympanic membrane. When instilling eardrops in an adult, a simple maneuver makes all the difference between medication that reaches the eardrum and drops that pull uselessly against the canal wall. The adult ear canal curves slightly upward and forward from the outer ear to the eardrum. The outer cartilaginous portion is mobile while the inner bony portion is fixed. Pulling the pinner upward and back realigns these two segments, straightening the canal into a direct funnel toward the tympanic membrane. In practice, warm the drops to body temperature first. Cold fluid can stimulate the vestibular system and cause dizziness. Then position the client with the affected ear up. Pull the pinner upward and back. Instill the drops without touching the canal, and have the client remain still for several minutes. A critical exam trap is mixing up the adult and pediatric techniques. In children under 3, the ear canal is more horizontal, so the pinner is pulled downward and back. The direction always follows the anatomy. Recognizing which age gets which maneuver is the core testing point. Remember, the up and back maneuver is not optional. It determines whether the medication actually reaches the inflamed tissue near the eardrum and delivers the intended therapeutic effect. Question 18. A client is taking tamoxifen for metastatic breast cancer and asks whether a family member with bladder cancer could also benefit. Which response by the nurse is most appropriate? Your options are A. It is used only to treat existing breast cancer. B. Yes, it also treats bladder cancer effectively. C. It treats existing breast cancer and prevents recurrence. D. Anyone diagnosed with cancer may take it safely. Take a second. Which answer would you pick? The correct answer is C. It treats existing breast cancer and prevents recurrence. C is correct because tamoxifen competes with estradiol for estrogen receptors in tissues with high receptor concentration. It treats metastatic breast carcinoma in women and men, delays recurrence after mastectomy, and reduces the risk of breast cancer in high-risk individuals. A is wrong because the word only ignores tamoxifen's role in preventing recurrence and reducing risk in high-risk clients. The medication has a wider indication than treatment alone, so this statement misrepresents its full clinical use. B is wrong because bladder cancer is not an indication for tamoxifen. The drug acts on hormone-sensitive breast tissue rather than urothelial cells, so recommending it for bladder cancer would mislead the family member about appropriate therapy. D is wrong because tamoxifen is not a universal cancer therapy and works only in tumors with estrogen receptors. Telling the family that anyone with cancer can take it ignores the receptor-specific mechanism and may delay appropriate evaluation. Tamoxifen is a selective estrogen receptor modulator, a drug that behaves differently depending on which tissue it's in. Understanding that mixed profile explains both its power against breast cancer and its side effects elsewhere. In breast tissue, tamoxifen occupies the estrogen receptor as an antagonist, preventing endogenous estrogen from binding and triggering tumor cell division. In the uterus and bone, the same drug acts as a partial agonist, producing effects rather than blocking them. Tamoxifen is used adjuvantly after surgery to suppress residual estrogen-driven cells and as prevention in high-risk women with atypical hyperplasia or lobular carcinoma in situ. Critically, it only works against estrogen receptor-positive tumors. Cancers like bladder cancer that are not estrogen receptor-driven will not respond. The adverse effect profile follows the antagonist-agonist split. Breast antagonism causes hot flashes and menopause-like symptoms. Uterine agonism raises the risk of endometrial cancer. Coagulation agonism increases the risk of deep vein thrombosis and pulmonary embolism. In postmenopausal bone, agonism is actually slightly protective. When you see tamoxifen on the exam, the testing point is almost always its receptor-specific boundary. It treats and prevents estrogen receptor-positive breast cancer, but a different malignancy means a different mechanism, and tamoxifen does not cross that line. Question 19. A client recently started on lisinopril for hypertension, reports a new dry, persistent cough and is considering stopping the medication. Which response by the nurse is most appropriate? Your options are A. Stop the drug immediately and switch to another agent. B. The cough often subsides. Do not discontinue without speaking with the prescriber. C. This finding indicates a possible pulmonary embolism. D. Continue the medication and ignore the cough entirely. Before I reveal it, which one do you think is right? The correct answer is B. The cough often subsides. Do not discontinue without speaking with the prescriber. B is correct because a persistent dry cough is a common adverse effect of angiotensin-converting enzyme inhibitors and often subsides after several weeks. The nurse instructs the client not to discontinue independently and to discuss the symptom with the prescriber at follow-up. A is wrong because independent discontinuation leaves the client's hypertension untreated and may be unnecessary if the cough resolves. The prescriber should be consulted before stopping, since alternative agents are reserved for persistent or intolerable cough. C is wrong because a pulmonary embolism presents with sudden onset dyspnea, pleuritic chest pain, and hypoxia rather than an isolated dry cough linked to a new antihypertensive. The cough described here matches a known medication effect. D is wrong because ignoring the cough without informing the prescriber misses an opportunity to evaluate persistence and consider alternative agents. Communication, rather than silent tolerance, is the appropriate response to a new medication-related symptom. A dry, persistent cough is one of the most recognizable adverse effects of ACE inhibitors like lisinopril, enalapril, and captopril. Understanding why it happens, a role, and how to manage it is a high-yield nursing exam concept. ACE normally does two things. It converts angiotensin 1 to angiotensin 2, and it breaks down bradykinin. When AC is blocked, bradykinin and substance P accumulate in the lungs, irritating the bronchial epithelium and triggering that characteristic dry, tickling cough. The cough is dry and non-productive, typically appearing within the first few weeks of starting the medication. The lungs sound completely clear on exam, and there is no fever or infection. The timeline and character of the cough are the strongest diagnostic clues. Management starts with reassurance. The cough is not damaging the lungs. Many clients tolerate it once they understand the cause. If it persists, the prescriber may switch to an angiotensin receptor blocker like losartan or valsartan, which targets the same pathway without accumulating bradykinin. Clients must never stop an ACE inhibitor on their own. Abrupt discontinuation can cause rebound blood pressure elevation and in heart failure or post-MI patients. The drug provides vital prognostic benefit. Always consult the prescriber before making any change. Question 20. A nurse is preparing an irritating intramuscular medication using the Z-track technique. Which injection site would the nurse select? Your options are A larger, deeper muscle, such as the ventrogluteal. B, the lateral aspect of the deltoid muscle. C, the intradermal layer on the inner forearm. D, the subcutaneous tissue of the abdomen. What's your answer? Commit to one before I continue. The correct answer is A, a larger, deeper muscle such as the ventrogluteal. A is correct because the Z-track method requires a larger, deeper muscle such as the ventrogluteal, so the surrounding tissue mass can seal the medication and prevent irritating fluid from tracking back through subcutaneous tissue. This site is preferred for staining or caustic intramuscular agents. B is wrong because the deltoid is too small and shallow to seal an irritating medication using the Z-track technique. Backflow of the drug into subcutaneous tissue is more likely in a shallow muscle, increasing the risk of skin staining and irritation. C is wrong because the intradermal layer is not a muscle and is reserved for small test doses just beneath the skin. The Z-track procedure relies on the depth of a true muscular compartment, which intradermal tissue cannot provide. D is wrong because the subcutaneous abdominal tissue is reserved for medications such as insulin and certain heparins. The Z-track method is by definition an intramuscular procedure and cannot be performed in subcutaneous fat tissue. The Z-track technique is a specialized intramuscular injection method that traps medication deep within the muscle, preventing it from leaking back into superficial tissue. It's reserved for medications that are irritating, staining, or toxic to subcutaneous layers. Before insertion, the non-dominant hand displaces skin and subcutaneous tissue laterally by about 1 inch. The needle enters straight into muscle, medication is injected slowly, and the needle is held for 10 seconds. When tissue is released after withdrawal, it snaps back and seals the track, trapping medication in the muscle. Z-track is indicated when the medication itself would cause pain, staining, or local reaction if it leaked into subcutaneous tissue. Classic examples include iron dextran, hydroxyzine, and some depot antipsychotics. Site selection is critical. The ventrogluteal is preferred because the gluteus medius and minimus provide thick muscle bulk with no major nerves or vessels nearby. The deltoid is too thin for irritating volumes, and the dorsogluteal is avoided due to proximity to the sciatic nerve. When the exam stem mentions Z-track, lateral displacement, or an irritating medication like iron dextran, The answer points to the ventrogluteal site. Distractors pairing Z-track with the deltoid or a subcutaneous site misread the depth and volume requirements entirely. Question 21. A nurse is caring for an adult client with acute myelocytic leukemia receiving busulfan therapy. Which laboratory value would the nurse monitor most closely? Your options are A. Serum clotting time, B. Serum potassium level, C. Blood glucose level, D. Serum uric acid level. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Serum uric acid level. D is correct because busulfan causes elevation of the serum uric acid level, which may produce uric acid nephropathy, renal stones, and acute kidney injury. Periodic monitoring allows early detection, so allopurinol can be prescribed to prevent renal complications during ongoing therapy. A is wrong because clotting time reflects platelets and coagulation function rather than the metabolic effects of busulfan. The medication is associated with hyperuricemia rather than with a coagulation derangement, so clotting studies would miss the priority concern. B is wrong because potassium monitoring is associated with cisplatin and several other drugs that disturb electrolytes. Busulfan does not typically affect serum potassium, so a potassium trend would not capture this medication's signature toxicity. C is wrong because glucose monitoring is appropriate for tacrolimus, atazanavir, or corticosteroid therapy. Hyperglycemia is not among the recognized adverse effects of busulfan, so a blood glucose trend would miss the uric acid problem this drug causes. When busulfan works against acute myelocytic leukemia, the rapid death of leukemic cells creates a predictable metabolic crisis. Understanding why cell breakdown is dangerous helps explain every monitoring and prevention step in the care plan. When leukemic cells die in large numbers, they spill potassium, phosphate, and nucleic acids into the blood. Xanthine oxidase then converts those nucleic acids into uric acid, which is poorly soluble at physiologic pH and tends to crystallize inside the renal tubules, threatening acute kidney injury. The resulting metabolic disturbances form a recognizable cluster: rising uric acid, rising potassium, rising phosphorus, and falling calcium. Of these, uric acid rises earliest and is the primary early warning target during the first days of effective chemotherapy. Prevention is built into the regimen. Generous IV hydration promotes brisk urine output to flush metabolites. Allopurinol blocks xanthine oxidase before uric acid builds up. For very high tumor burden or rapidly rising levels despite allopurinol, rusbricase enzymatically breaks down existing uric acid. Myelosuppression from busulfan is real but develops more slowly in the first critical days of therapy. A trending uric acid level is the sharpest early signal that tumor lysis syndrome is developing and that intervention is needed now. Question 22. A client taking digoxin reports new nausea, anorexia, and 1 episode of vomiting at home. Which interpretation of these findings is most accurate? Your options are A. Visual disturbances typically appear before these symptoms. B. Bradycardia is the first sign of toxicity. C. Gastrointestinal symptoms appear as the earliest signs of toxicity. D. Hypertension is the first sign of toxicity. Which would you go with? Lock it in before the reveal. The correct answer is C. Gastrointestinal symptoms appear as the earliest signs of toxicity. C is correct because early digoxin toxicity presents with gastrointestinal manifestations including anorexia, nausea, vomiting, and diarrhea before heart rate abnormalities or visual disturbances appear. The nurse recognizes this pattern and confirms by checking the serum digoxin level promptly. A is wrong, because visual disturbances such as yellow-green halos are real digoxin toxicity findings but appear later than gastrointestinal symptoms. The typical sequence places anorexia, nausea, and vomiting first, with visual changes following. B is wrong because bradycardia and heart rate abnormalities follow gastrointestinal symptoms in the digoxin toxicity sequence. The earliest warning signs are anorexia, nausea, vomiting, or diarrhea, which prompt evaluation before cardiac changes develop. D is wrong because hypertension is not part of the classic digoxin toxicity presentation. Digoxin slows the heart rather than raises blood pressure, and the earliest toxicity findings are gastrointestinal rather than cardiovascular. Digoxin has one of the narrowest therapeutic windows in cardiac pharmacology, making early recognition of toxicity a critical clinical skill. The earliest warning signs are easy to dismiss, but on a patient taking digoxin, they demand immediate attention. Digoxin works by inhibiting the sodium-potassium ATPase pump on cardiac myocytes. This raises intracellular sodium, slows the sodium-calcium exchanger, and increases intracellular calcium, boosting contractility in heart failure and slowing conduction through the AV node in atrial fibrillation. At toxic levels, the exact same mechanism triggers dangerous arrhythmias. Gastrointestinal symptoms, nausea, anorexia, and vomiting, appear first because digoxin stimulates the chemoreceptor trigger zone in the brainstem. Visual disturbances like yellow or green halos and cardiac arrhythmias only emerge at higher toxic serum levels. Several factors push patients toward toxicity even at seemingly stable doses. Hypokalemia is especially dangerous because it makes the sodium-potassium pump more sensitive to digoxin. Adding a diuretic, a common scenario in combined heart failure regimens, can quietly drop potassium and tip a therapeutic level into a toxic one. When a patient on digoxin develops new nausea, anorexia, or vomiting, do not attribute it to a stomach bug. Check a serum digoxin level and potassium value immediately. Waiting for visual disturbances or arrhythmias means the toxicity has already advanced further than necessary. Question 23. A nurse is teaching a client newly diagnosed with type 2 diabetes who has been prescribed repaglinide and metformin. Which instruction about repaglinide is essential? Your options are: A. Take repaglinide at bedtime each night. B. Skip the repaglinide dose whenever a meal is missed. C. Take repaglinide 1 hour after the meal is eaten. D. Take repaglinide only at the same time as metformin. Don't overthink it. Which one feels right? The correct answer is B. Skip the repaglinide dose whenever a meal is missed. B is correct because repaglinide is a rapid-acting meglitinide that stimulates pancreatic insulin secretion before a meal. The dose is taken about 30 minutes before eating, and if the client skips a meal, the dose must be withheld to prevent hypoglycemia from unopposed insulin release. A is wrong because bedtime dosing is unsafe with repaglinide. The medication is timed to coordinate insulin release with the carbohydrate load of an upcoming meal, so dosing at bedtime when no meal is eaten would cause significant nocturnal hypoglycemia. C is wrong because taking repaglinide after eating misses the timing needed for insulin release to match carbohydrate absorption. The medication is taken 30 minutes before the meal and withheld when no meal will be eaten. D is wrong because linking repaglinide dosing solely to metformin ignores its meal-paired function. Metformin does not coordinate with eating in the same way, so repaglinide must be timed to meals rather than to another agent. Repaglinide is a meglitinide class insulin secretagogue used in type 2 diabetes. Its most important teaching point is a simple rule. The dose is paired with the meal, and if the meal is skipped, so is the dose. Repaglinide binds to the potassium channel on the pancreatic beta cell and closes it. The resulting depolarization opens calcium channels, triggering a rapid burst of insulin release that closely mirrors glucose absorption from a meal. The key pharmacokinetic difference from sulfonylureas is duration. Repaglinide has a rapid onset and short half-life, so insulin release matches the meal. Sulfonylureas, like glyburide, produce prolonged insulin output for hours, regardless of whether another meal arrives. The short duration is what makes flexible dosing possible. If a meal is eaten, give repaglinide within 15 minutes. If the meal is skipped, skip the dose entirely. If the meal is delayed more than an hour or two, hold the dose until eating is about to begin. Metformin and repaglinide are a common early pairing in type 2 diabetes. Metformin controls fasting glucose by reducing hepatic production and is taken twice daily regardless of meal size. Repaglinide handles the postprandial rise and follows the meal, making the combination complementary and flexible. Question 24. A nurse is preparing to administer a sustained-release pain medication to a client with dysphagia who asks to have the pill crushed into pudding. Which response by the nurse is most appropriate? Your options are: A. Crushing the tablet would improve its bioavailability. B. Crushing the tablet would reduce the risk of aspiration. C. Crushing the tablet is required for proper absorption. D. Crushing the tablet would destroy its release mechanism. Got a guess? Lock it in. The correct answer is D. Crushing the tablet would destroy its release mechanism. D is correct because sustained release tablets are formulated to release drug gradually, and crushing the tablet destroys the mechanism that controls release. The result is delivery of the entire dose at once, producing a toxic plasma peak, so an alternate immediate release formulation must be requested. A is wrong because crushing does not enhance bioavailability of sustained release products. Disrupting the controlled release matrix turns a slow release tablet into an immediate release dose, which produces a dangerous peak rather than a beneficial increase in availability. B is wrong because crushing the tablet does not reduce aspiration risk and may complicate swallowing further by changing texture. The prohibition exists because of pharmacologic timing rather than airway protection mechanics. C is wrong because sustained release absorption is engineered to occur slowly in the small intestine. Physical disruption of the tablet cancels the intended slow profile rather than being required for absorption to take place. Sustained release medications are engineered to deliver a drug gradually over many hours. Understanding why crushing them is so dangerous requires a look at how these release mechanisms actually work and what happens when they're destroyed. There are three main sustained release designs: a matrix tablet where drug diffuses through a polymer lattice, an osmotic pump system where tiny laser drilled holes meet a drug exit, and coated beads inside a capsule where each bead dissolves at a different rate. All three are undone instantly by crushing. When a sustained release opioid is crushed, the total dose intended for 12 to 24 hours floods the bloodstream within minutes. For opioids like morphine, oxycodone, or hydromorphone, that sudden bolus far exceeds what the body can safely tolerate, producing respiratory depression, profound sedation, and potentially death. When a patient with dysphagia cannot swallow a sustained release tablet, the answer is never to crush it. It's to change the formulation. Safe alternatives include oral liquid opioids, transdermal fentanyl patches, or carefully dosed immediate release preparations. The nurse's role is to recognize the crushing request as a trigger to contact the prescriber for a formulation switch. Sweetening a crushed tablet in pudding does nothing to restore the release mechanism. The clinical teaching is simple. Sustained release means the formulation is the safety plan. and physical disruption destroys it. Always consult the pharmacist or prescriber before manipulating any extended release product. Question 25. A nurse is teaching a client about a newly prescribed guaifenesin expectorant for productive cough. Which instruction would the nurse emphasize? Your options are A. Take each dose with a full glass of water. B. Avoid all fluids for 1 hour after the dose. C. Take the medication only at bedtime each day. D. Mix the dose with a glass of whole milk. Which one is it? Pause the video if you need more time. The correct answer is A. Take each dose with a full glass of water. A is correct because guaifenesin must be taken with a full glass of water so respiratory secretions can be thinned and cleared from the airways. Adequate hydration is integral to how the expectorant mobilizes thick mucus, so the fluid volume is part of the therapeutic effect. B is wrong because avoiding fluids defeats the expectorant mechanism, which depends on hydration to liquefy secretions. Restricting fluids would leave mucus thick and difficult to expel, the opposite of the medication's intended action. C is wrong because bedtime-only dosing concentrates the effect into the night and may worsen daytime cough when secretion clearance is most needed. Guaifenesin is dosed throughout the day with consistent fluid intake. D is wrong because mixing the dose with milk is not the recommended administration. Water is the vehicle that supports the expectorant action through hydration, while milk does not provide the same secretion thinning benefit. Guaifenesin is an expectorant that thins mucus, so it can be cleared by coughing. But here's the key principle that drives every teaching point. The drug's mechanism depends entirely on adequate body water. Guaifenesin acts through two pathways: direct stimulation of secretory glands in the respiratory tract and an osmotic shift of water into airway secretions. Both pathways require sufficient body fluid to thin mucus effectively. Without it, the drug simply cannot work. Every dose should be taken with a full glass of water, not a small sip. Generous fluid intake throughout the day and added moisture from a humidifier or steam inhalation further support mucus clearance. Together, these measures amplify what the drug alone cannot accomplish. Don't confuse expectorants with cough suppressants. Guaifenesin targets productive coughs with thick sputum and makes coughing more effective. Dextromethorphan, a suppressant, reduces the cough reflex centrally and is used for dry, non-productive coughs, the opposite clinical goal. On the exam, whenever you see guaifenesin, hydration, or full glass of water, the testing point is almost always the hydration teaching. Any answer that downplays fluid intake or suggests restricting fluids misunderstands how this drug works. Question 26. A client with schizophrenia has been newly started on clozapine for treatment-resistant symptoms. Which laboratory study would the nurse monitor most closely? Your options are A. Random blood glucose level. B. Liver function and bilirubin studies. C. White blood cell count for agranulocytosis. D. Coagulation panel with prothrombin time. Take a second. Which answer would you pick? The correct answer is C. White blood cell count for agranulocytosis. C is correct because clozapine carries a black box warning for agranulocytosis. So the white blood cell count is monitored on a strict schedule throughout therapy. The nurse instructs the client to report sore throat, fever, and malaise immediately as early signs of bone marrow suppression. A is wrong because blood glucose may rise with antipsychotic therapy, but is not the primary clozapine monitoring focus. The agranulocytosis risk drives a specific leukocyte surveillance schedule rather than glycemic trending. B is wrong because hepatic monitoring belongs to medications like dantrolene or methotrexate. Clozapine carries a specific black box risk for life-threatening bone marrow toxicity, which liver function studies would entirely miss. D is wrong because coagulation studies evaluate bleeding and clotting status for anticoagulants such as warfarin or heparin. They do not detect granulocyte depletion, the priority safety concern with clozapine therapy. Clozapine is a last resort, a typical antipsychotic reserved for treatment-resistant schizophrenia. What makes it unique, and uniquely dangerous, is its risk of agranulocytosis, a severe drop in neutrophils that leaves patients defenseless against bacterial infection. The mechanism involves a toxic metabolite that selectively damages neutrophil precursors in the bone marrow. This process can begin silently. There are no warning symptoms, which is why lab monitoring is the only reliable safeguard. Monitoring follows a strict schedule, weekly for the first 6 months, every 2 weeks for the next 6 months, then monthly for the duration of treatment. Clozapine cannot be dispensed without a documented neutrophil count above the required threshold. Clozapine also causes metabolic syndrome, myocarditis, seizures, sialorrhea, constipation, and orthostatic hypertension. Each has its own monitoring plan, but none are as rigid as the ANC requirement. Missing a granulocytosis carries the highest consequence. When an exam stem mentions clozapine or treatment-resistant schizophrenia, the testing point is almost always the white blood cell and absolute neutrophil count monitoring. Sedation and weight gain are common to all atypicals. The ANC protocol is what sets clozapine apart. Question 27. A new parent suggests hiding an infant's antibiotic in a bottle of milk during feeding. Which response by the nurse best supports proper administration? Your options are: A. Milk will chemically neutralize the antibiotic. B. The infant may not finish the bottle, so the dose is lost. C. The medication will harden inside the nipple. D. The infant will become immune to the antibiotic. Before I reveal it, which one do you think is right? The correct answer is B. The infant may not finish the bottle, so the dose is lost. B is correct because mixing medication into a bottle is discouraged because the infant may not consume the entire serving, so the full prescribed dose is not delivered. The child may also refuse the same food in the future, which complicates ongoing feeding and care. A is wrong because while a few specific medications interact with dairy chemistry, the central concern with hiding medication in food is incomplete consumption rather than chemical neutralization. Dose accuracy is the priority teaching point. C is wrong because hardening inside the nipple may occur with certain formulations, but is not the principal reason this practice is discouraged. The teaching focuses on the behavioral and dosing consequences of mixing medications into feedings. D is wrong because infants do not develop immune resistance to antibiotics by ingestion through a particular vehicle. Resistance is a microbial phenomenon, while the actual concern relates to incomplete dose delivery and future food aversion. When giving antibiotics to infants, one of the most important principles is ensuring the full dose is reliably delivered. This diverges from what might seem like a practical, family-friendly approach. If an antibiotic is hidden in a full bottle of formula and the infant stops feeding halfway through, only a fraction of the dose is absorbed. The rest is discarded with the remaining milk, making the total dose received completely uncertain. The correct technique is to give the medication separately before the feeding. Use an oral syringe directed toward the inside of the cheek, in small increments to prevent gagging, with the head slightly elevated. Once the dose is confirmed swallowed, the feeding proceeds normally. Antibiotics are dosed to keep blood levels above the minimum inhibitory concentration for the full course of therapy. Partial doses drop below that threshold, allowing bacteria to survive, rebound, and potentially develop resistance. The teaching point for parents is simple. Give the medication first with a syringe. Confirm it is swallowed. Then feed as usual. This keeps the dose reliable, the timing preserved, and the risk of resistance low. Question 28. A nurse is monitoring a hospitalized client receiving an antipsychotic who develops hyperpyrexia, severe muscle rigidity, autonomic instability, and altered consciousness. Which complication would the nurse suspect? Your options are tardive dyskinesia of late onset, B. Hypertensive crisis from a tyramine reaction, C. Acute dystonic reaction syndrome, D. Neuroleptic malignant syndrome. What's your answer? Commit to one before I continue. The correct answer is D. Neuroleptic malignant syndrome. D is correct because neuroleptic malignant syndrome features hyperpyrexia, autonomic dysfunction, skeletal muscle rigidity, altered consciousness, and elevated creatine phosphokinase. The nurse notifies the prescriber, prepares to discontinue the antipsychotic, and initiates cooling and supportive measures immediately to prevent fatal outcomes. A is wrong because tardive dyskinesia involves involuntary tongue protrusion, chewing motions, and limb movements rather than fever and rigidity. The presentation in this client matches the febrile severity of neuroleptic malignant syndrome rather than a chronic movement disorder. B is wrong because a tyramine-induced hypertensive crisis is associated with monoamine oxidase inhibitor therapy rather than antipsychotics. That presentation would feature sudden blood pressure spikes and severe headache without hyperpyrexia and lead pipe rigidity. C is wrong because acute dystonic reactions produce sudden involuntary muscle contractions such as ocular gyric crisis or torticollis without fever or altered consciousness. The current constellation matches the more severe and febrile syndrome instead. Neuroleptic malignant syndrome is a rare but life-threatening emergency caused by antipsychotic medications. Understanding its mechanism, clinical picture, and how to distinguish it from lookalike syndromes is essential for safe practice. NMS presents with 4 hallmark findings: hyperpyrexia, lead pipe rigidity, autonomic instability, and altered mental status. This tetrad develops over hours to days after exposure to an antipsychotic agent. The mechanism centers on sudden dopamine D2 receptor blockade in the CNS. Hypothalamic blockade disrupts thermoregulation and drives the fever. Basal ganglia blockade produces the rigidity. Downstream effects on autonomic pathways cause the cardiovascular instability. Higher potency typical antipsychotics like haloperidol and fluphenazine carry the greatest risk. The laboratory hallmark is markedly elevated creatine kinase from sustained muscle damage, often in the thousands. Management begins with immediate discontinuation of the antipsychotic, then supportive care with cooling and IV fluids. Dantrolene reduces rigidity and bromocriptine or amantadine help restore dopaminergic tone. Recovery takes days to weeks. The key exam trap is confusing NMS with serotonin syndrome. Serotonin syndrome follows serotonergic medications, often 2 agents combined, and produces clonus and hyperreflexia rather than lead pipe rigidity. The medication history is what separates them. Antipsychotic exposure points to NMS every time. Question 29. A nurse is administering atropine sulfate eye drops to a 6-month-old infant before an eye examination. Which assessment is the priority following administration? Your options are A. Monitor for abdominal distension, B. Monitor for projectile vomiting, C. Monitor for bulging of the fontanelle, D. Monitor for jaundice and skin rash. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Monitor for abdominal distension. A is correct because ophthalmic atropine in an infant may produce systemic anticholinergic absorption that slows gastrointestinal motility and causes abdominal distension. The nurse keeps a record of bowel movements and auscultates bowel sounds during therapy with this medication. B is wrong because projectile vomiting is associated with pyloric stenosis rather than ophthalmic atropine. The priority systemic concern with this medication in infants is decreased bowel motility, not gastric outflow obstruction. C is wrong because A, bulging fontanelle signals increased intracranial pressure, which is not an effect of ophthalmic atropine. The priority surveillance after this medication targets gastrointestinal slowing rather than neurological pressure changes. D is wrong because jaundice and skin rash are not characteristic systemic effects of ophthalmic atropine in infants. Bowel distension from anticholinergic action is the priority monitoring focus rather than hepatic or dermatologic findings. Atropine eye drops are used to dilate pupils and paralyze accommodation for pediatric eye exams. While these are the intended effects, infants face a unique risk that adults largely do not: significant systemic absorption. After instillation, atropine drops drain through the nasolacrimal duct into the nasal cavity, where they are swallowed and absorbed through the gastrointestinal tract. In an infant's small body, this absorbed dose represents a significant pharmacologic load. The resulting anticholinergic toxidrome can include dry mouth, dry skin, fever, flushed face, tachycardia, abdominal distension, urinary retention, and altered mental status. In infants, abdominal distension is the priority concern because decreased gut motility can progress to functional ileus and cannot be self-reported. To reduce systemic absorption, apply firm pressure at the inner corner of the eye over the nasolacrimal duct for at least 1 minute after drop instillation. Using the lowest effective concentration and considering alternative agents like cyclopentolate are additional protective measures. Remember, pupil dilation is the therapeutic goal, not the concern. When atropine and infant appear together on an exam, the testing point is systemic anticholinergic monitoring, especially abdominal distension from gut hypomotility. Question 30. A nurse is teaching a client taking levothyroxine sodium about symptoms that must be reported. Which finding would indicate excessive thyroid hormone effect? Your options are A. Excessively dry skin, B. Persistent daily fatigue, C. Tremors and palpitations, D. New cold intolerance. Which would you go with? Lock it in before the reveal. The correct answer is C. Tremors and palpitations. C is correct because excessive doses of levothyroxine produce signs of hyperthyroidism, including tachycardia, chest pain, tremors, nervousness, insomnia, heat intolerance, and sweating. These findings must be reported because they signal toxicity that requires the prescriber to adjust the dose. A is wrong because dry skin is a classic finding of insufficient thyroid hormone, which describes inadequate replacement rather than excess. The client would actually report increased perspiration when the dose is too high during therapy. B is wrong because persistent fatigue reflects the underlying hypothyroidism being treated and points toward an inadequate dose rather than an excessive one. Insomnia and restlessness, not fatigue, would suggest the dose is too high. D is wrong because new cold intolerance is a hypothyroid feature reflecting undertreatment. Heat intolerance would appear when metabolic activity is excessive, so this finding signals the dose may need to be increased rather than reduced. Levothyroxine replaces deficient thyroid hormone in hypothyroidism, but when the dose is too high, the client tips into a hypothyroid state. The key exam skill is recognizing that new tremors and palpitations in someone on chronic levothyroxine signal over replacement, not the original disease. Excess thyroid hormone upregulates beta-adrenergic responsiveness, raising heart rate, contractility, and basal metabolic rate. This produces a cluster of sympathetic symptoms: tremors, palpitations, heat intolerance, weight loss, sweating, and anxiety with insomnia. TSH provides the cleanest feedback for titration. When thyroid hormone is adequate, TSH is suppressed. When the dose is too low, TSH rises. Therapy is started conservatively and adjusted in small increments every 6 to 8 weeks to avoid overshooting into the hyperthyroid range. Absorption is highly sensitive to timing and co-ingested substances. Calcium, iron, magnesium, soy, and certain antacids bind the drug and reduce absorption. Consistent daily timing and separation from interfering substances keep the effective dose stable. The exam trap is misreading over-replacement as the original hypothyroid disease. Under-replacement brings cold intolerance, weight gain, and bradycardia. Over-replacement brings heat intolerance, palpitations, and tremors. The direction of the symptom change points directly to whether the dose needs to go up or come down. Question 31. A nurse is monitoring an HIV seropositive client receiving stavudine. Which parameter would the nurse monitor most closely during therapy? Your options are A. Appetite at each meal, B. The client's gait while walking, C. Daily level of consciousness, D. Gastrointestinal output volumes. Don't overthink it. Which one feels right? The correct answer is B. The client's gait while walking. B is correct because stavudine can cause peripheral neuropathy, so the nurse monitors the client's gait closely and asks about paresthesia during therapy. Early detection allows the medication to be discontinued before permanent nerve damage develops in the lower extremities. A is wrong because tracking appetite supports general nutritional assessment but does not capture the neurological adverse effect of stavudine. The medication's signature toxicity targets peripheral nerves rather than gastrointestinal intake. C is wrong because level of consciousness reflects cortical function rather than peripheral nerve health. Stavudine primarily affects peripheral nerves with paresthesia and gait disturbance, so neurological surveillance focuses on the lower extremities. D is wrong because stool output volumes do not reflect peripheral neuropathy. The priority monitoring focus for stavudine is gait and paresthesia, which evaluate lower extremity nerve function rather than gastrointestinal output. Stavudine is a nucleoside reverse transcriptase inhibitor with a distinctive adverse effect profile. Its most clinically important toxicity is peripheral neuropathy, and the earliest sign is often detectable at the bedside before the patient even reports a complaint. Stavudine inhibits mitochondrial DNA polymerase gamma in peripheral nerve fibers. Because long axons are highly energy dependent, the distal segments fail first, a pattern called dying back axonal injury, producing paresthesias, burning pain, and loss of vibratory and proprioceptive sense beginning in the feet. As proprioception declines, patients compensate in predictable ways. They widen their stance for stability, shorten their step length, and slow their cadence. Observing the patient walk from the waiting room to the exam room is a sensitive and cost-free screening tool. Each NRTI carries a signature toxicity worth matching. Stavudine pairs with gait observation and neuropathy assessment. Stavudine prompts monitoring for anemia, tenofovir for renal and bone effects, and didanosine for pancreatitis. Knowing these distinctions prevents confusing one agent's profile for another's. Stavudine-induced neuropathy can become permanent if caught late. Stopping or switching the drug early allows partial recovery. The gait observation is the testable priority because functional change precedes both laboratory findings and patient-reported symptoms. Question 32. A nurse is reviewing the timing of antacid administration. Which interval would the nurse allow between the antacid and any other oral medication? Your options are A. 1 hour between doses, B. 30 minutes between doses, C. 15 minutes between doses, D. 4 hours between doses. Got a guess? Lock it in. The correct answer is A. 1 hour between doses. A is correct because to prevent interactions and binding interference, 1 hour should pass between antacid administration and any other oral medication. This interval protects the absorption of the other drug, since antacids reduce gastric acidity and bind many co-administered medications. B is wrong because 30 minutes is too short to prevent binding interactions in the gastrointestinal tract. A full 60-minute separation is needed so other prescribed medications can be absorbed properly without the antacid altering their bioavailability. C is wrong because 15 minutes leaves the antacid still active in the stomach when the other medication is taken. The required interval is 1 hour to allow the gastric environment to recover before introducing another drug. D is wrong because 4 hours is unnecessarily long and impractical for typical dosing schedules. The standard interval is 1 hour, which is sufficient to prevent interactions while keeping the medication regimen manageable for the client. Antacids neutralize gastric acid effectively, but that same chemistry can interfere with how other oral medications are absorbed. Understanding why helps you time medications safely. There are two main mechanisms. First, chelation. Tetracyclines and fluoroquinolones bind metal ions in the antacid, forming insoluble complexes that cannot be absorbed. Second, the rising gastric pH impairs dissolution of acid-dependent drugs like ketoconazole and itraconazole. Changes in gastric emptying can further slow absorption. Chelation is the key mechanism for antibiotics like tetracycline. The drug physically binds to calcium, magnesium, or aluminum ions in the antacid, forming a complex the gut wall cannot absorb, dramatically reducing the drug's bioavailability. The practical rule is to separate antacids from other oral medications by at least 1 hour before or 2 to 4 hours after, depending on the specific drug. Always verify the prescribing information for interaction-sensitive medications like tetracyclines, fluoroquinolones, and azole antifungals. Remember, antacid interactions are pharmacokinetic, not pharmacodynamic. They work through chelation and pH change, not receptor binding. When you see antacid alongside any oral medication, the exam is testing whether you know to separate their timing. Question 33. A nurse is monitoring a client newly prescribed bupropion who experiences a sudden generalized motor event. Which finding indicates the client may be receiving an excessive dose? Your options are A. Constipation after meals, B. Dizziness on standing up, C. Mild weight gain over weeks, D. Seizure activity occurring. Which one is it? Pause the video if you need more time. The correct answer is D. Seizure activity occurring. D is correct because bupropion lowers the seizure threshold, and seizure activity is the adverse effect that signals excessive dosing. The nurse withholds the next dose, notifies the prescriber for immediate dose review, and ensures airway and injury protection during any further seizure activity. A is wrong because constipation is a common gastrointestinal effect of many antidepressants, but does not specifically indicate excessive bupropion dosing. The hallmark toxicity for bupropion is seizure activity rather than slowed bowel motility. B is wrong because orthostatic dizziness reflects autonomic blood pressure shifts seen at therapeutic doses of many medications, This nonspecific finding does not distinguish the seizure threshold concern unique to bupropion overdose. C is wrong because weight gain is not the bupropion adverse effect that signals excessive dosing. The seizure threshold reduction marks bupropion specifically and identifies overdose risk most directly for clinical purposes. Bupropion is unique among antidepressants because it lowers the seizure threshold in a dose-dependent way. Understanding why this happens and how to recognize and respond to it is the core clinical skill being tested. Seizure risk rises with higher doses and with any condition that already stresses neuronal excitability. This is exactly why bupropion is contraindicated in eating disorders, in recent withdrawal states, and when combined with other medications that lower the threshold. The hallmark event is a tonic-clonic seizure, sudden generalized stiffening, followed by rhythmic bilateral jerking, then a postictal period of confusion and somnolence. This full pattern distinguishes a true seizure from syncope, panic, or a psychogenic event. Clinical response follows standard seizure management, protects the client, never insert anything into the mouth, time the event, and reposition onto the side once convulsing stops to protect the airway. Afterward, assess for injuries, check vitals, and review the medication list, especially any recently started agents like bupropion. When exam STEM language lines up bupropion initiation with a generalized motor event and postictal confusion, the answer is seizure. Framing it as anxiety or syncope misses the motor pattern. A first bupropion-induced seizure typically means holding the drug and switching to a lower-risk antidepressant. Question 34. A nurse is preparing an intramuscular injection for a 4-month-old infant. Which site would the nurse select as the safest at this age? Your options are A. Ventrogluteal muscle group, B. Lateral deltoid muscle group, C. Vastus lateralis muscle group, D. Rectus femoris muscle group. Take a second. Which answer would you pick? The correct answer is C. Vastus lateralis muscle group. C is correct because the vastus lateralis is the only safe intramuscular site for an infant because other muscle groups have not yet developed sufficient mass to absorb medication without injury. Site selection follows muscle development and the size of the child rather than personal preference. A is wrong because the ventrogluteal site requires muscle development that an infant has not yet achieved at 4 months. This site becomes safe as the child grows, but is classified as unsafe for injection in infancy. B is wrong because the deltoid is too small in an infant to safely accept an intramuscular injection without risk to surrounding nerves and vessels. This site is reserved for older children and adults with developed shoulder musculature. D is wrong because the rectus femoris is not the preferred infant site and is classified as unsafe at this age. Infants are directed specifically to the vastus lateralis, which provides the necessary muscle mass for safe injection. When giving an intramuscular injection to an infant, site selection is driven by muscle development, not habit. The standard adult site, the deltoid, is simply not appropriate for a baby under 1 year old. The deltoid in a 4-month-old lacks sufficient muscle bulk for a safe injection. The gluteal muscles stay underdeveloped until the child begins sustained walking and running, and they sit dangerously close to the sciatic nerve. The vastus lateralis is located by dividing the thigh from the greater trochanter to the lateral epicondyle into thirds. The injection targets the middle third on the anterolateral aspect, with the needle directed straight in or slightly anterior. The vastus lateralis remains the preferred site through about the 3rd year of life, once a child has developed gluteal mass through walking and running. Around age 3, the ventrogluteal site becomes acceptable and is often preferred from that point forward. On the exam, when you see an infant under 1 year needing an intramuscular injection? The answer is always the vastus lateralis. Choices suggesting the deltoid or any gluteal site in an infant are distractors rooted in adult anatomy, not pediatric development. Question 35. A client receiving a potent alpha for anemia is being monitored for therapeutic response. Which hematocrit value indicates that the medication's therapeutic effect has appeared? Your options are A, less than 15% hematocrit, B, 30 to 33% hematocrit, C, 42 to 47% hematocrit, D, greater than 50% hematocrit. Before I reveal it, which one do you think is right? The correct answer is B, 30 to 33% hematocrit. B is correct because the therapeutic effect of apoetin alpha appears when the hematocrit reaches 30 to 33%, which marks adequate stimulation of red blood cell production. Hematocrit elevation beyond this range is monitored closely to avoid thrombotic complications from supraphysiologic levels. A is wrong because a hematocrit less than 15% represents profound anemia rather than therapeutic response. This value would prompt urgent transfusion considerations rather than confirmation that erythropoietin therapy is producing red cell production. C is wrong because 42 to 47% falls within or near the normal hematocrit range and exceeds the therapeutic threshold for apoetin alpha. Reaching this value during therapy may indicate excessive response requiring dose adjustment. D is wrong because a hematocrit greater than 50% is supranormal and signals that the medication is producing too much effect. This level carries thrombotic risk and would prompt holding the medication rather than confirming therapeutic response. Apoetin alpha is a synthetic erythropoietin used to treat anemia in chronic kidney disease and other conditions where the body can't produce enough of its own. Understanding why the target hematocrit is set lower than normal is the core clinical principle here. Apoetin alpha binds receptors on erythroid progenitor cells in the bone marrow, stimulating their proliferation and maturation into circulating red blood cells. The response is gradual, and must what antibodies reticulocyte counts shift within days, but hematocrit changes take weeks, reflecting the natural pace of red blood cell production. Large clinical trials showed that correcting hematocrit above 36% in chronic kidney disease significantly raises the risk of 3 cardiovascular events: stroke, myocardial infarction, and venous thromboembolism. Increased blood viscosity and platelet activation at higher hematocrits are thought to drive this danger. The safe target hematocrit is 30 to 33%, well below the normal adult range of around 40%. Iron stores must be adequate for the drug to work, so iron saturation and ferritin are monitored alongside hematocrit, and the dose is titrated based on response. The classic exam trap is choosing a normal range hematocrit as the goal. For apoetin alpha, lower targets are deliberately safer. If you see apoetin alpha, erythropoietin, or anemia of chronic kidney disease, the answer is 30 to 33%, not the 40s. Question 36. A client with Crohn's disease is scheduled to receive an infliximab infusion. Which intervention best evaluates the effectiveness of the treatment? Your options are A. Checking frequency and consistency of bowel movements, B. Checking serum liver enzyme levels surrounding the infusion, C. Monitoring the leukocyte count for 2 days after infusion, D. Performing hematest on gastric fluids after infusion. What's your answer? Commit to one before I continue. The correct answer is A. Checking frequency and consistency of bowel movements. A is correct because Crohn's disease manifests with diarrhea and abdominal pain. and infliximab reduces colonic inflammation. Checking frequency and consistency of bowel movements directly evaluates whether the medication is producing the intended anti-inflammatory effect on the client's gastrointestinal tract. B is wrong because liver enzyme monitoring tracks hepatotoxicity rather than Crohn's disease response. Effectiveness for this condition appears in the bowel pattern, so liver studies would measure safety rather than the therapeutic outcome of the infusion. C is wrong because leukocyte counts evaluate infection risk rather than inflammatory bowel disease response. Bowel movement frequency and consistency reflect the reduction in colonic inflammation, so the leukocyte trend would miss the therapeutic outcome. D is wrong because gastric bleeding is not a principal manifestation of Crohn's disease. The medication targets inflammation in the lower bowel, so a gastric hematest would not reflect the therapeutic effect of infliximab in this client. Infliximab is a monoclonal antibody that neutralizes tumor necrosis factor alpha, the key cytokine driving chronic bowel inflammation in Crohn's disease. Understanding how it works helps explain exactly how nurses evaluate whether it's effective. In Crohn's disease, TNF-alpha is overproduced, recruiting inflammatory cells and damaging the intestinal lining. Infliximab binds and neutralizes this cytokine, allowing the mucosa to heal and the bowel architecture to recover. The most direct way to evaluate infliximab is by tracking bowel symptoms. A reduction in stool frequency, a return to more form consistency, and decreased abdominal pain and urgency are the primary bedside markers that therapy is working. Laboratory markers like C-reactive protein, ESR, and fecal calprotectin can track inflammation, and endoscopy with biopsy is the gold standard for mucosal healing. These are valuable tools, but they are not the practical day-to-day measure the nurse uses at every infusion visit. When an exam question pairs infliximab with Crohn's disease, the testing point is always the symptom-based assessment, stool frequency and consistency, not a lab value or procedure. That bowel pattern is what gets asked about, documented and trended at every appointment. Question 37. A nurse is providing dietary teaching to a client newly prescribed glimepiride for type 2 diabetes mellitus. Which item would the nurse instruct the client to avoid? Your options are A. Whole grain cereal at breakfast, B. Red meat at the evening meal, C. Carbonated beverages with meals, D. Alcoholic beverages of any kind. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Alcoholic beverages of any kind. D is correct because alcohol combined with glimepiride may produce a disulfiram-like reaction with flushing, palpitations, and nausea. Alcohol can also potentiate the hypoglycemic effect, so it must be avoided throughout therapy with the sulfonylurea agent. A is wrong because whole grain cereals are acceptable while taking glimepiride and do not trigger a disulfiram-like reaction. Complex carbohydrates support stable blood glucose and remain an appropriate part of the diabetic meal plan. B is wrong because red meats are an acceptable food choice with glimepiride and do not interact with the medication. Alcohol is the specific substance that produces the disulfiram-like reaction requiring strict avoidance. C is wrong because carbonated beverages do not produce a disulfiram-like reaction with glimepiride. Sugar-containing soft drinks may affect glycemic control, but do not carry the specific medication interaction that alcohol does. Glimepiride is a sulfonylurea, an insulin secretagogue used in type 2 diabetes. When clients ask about alcohol, the answer is total avoidance, not moderation, and there are two distinct reasons why. First, sulfonylureas inhibit aldehyde dehydrogenase, so acetaldehyde from alcohol accumulates and causes a disulfiram-like reaction, flushing, nausea, headache, and palpitations. Second, alcohol independently blocks gluconeogenesis, the liver's mechanism for producing glucose between meals, with glympyride continuing to drive insulin release for hours and the liver unable to produce glucose. Blood sugar can fall severely and stay low, often requiring intravenous dextrose rather than responding to oral fast-acting carbohydrate, because the hyperglycemia risk is severe and prolonged. Clients are taught to recognize symptoms, shakiness, sweating, hunger, and confusion, and to act immediately with fast-acting carbohydrate, recheck their glucose, and contact their provider if symptoms do not resolve. On the exam, a moderate alcohol guideline like 1 drink with a meal is the classic distractor. For sulfonylureas, both risks are dose-related and individually unpredictable. The only safe teaching is complete avoidance. Question 38. A nursing instructor asks students why learning medications by generic name first is the preferred strategy. Which response by a student is most accurate? Your options are: A. Brand names rotate every month. B. Brand names are no longer used in practice. C. Generic names appear on every medication label. D. Generic names are uniquely color-coded by drug class. Which would you go with? Lock it in before the reveal. The correct answer is C. Generic names appear on every medication label. C is correct because a medication label always contains the generic name, while the trade name may or may not appear. The licensure exam tests generic recognition for this reason, and reading labels by generic name keeps the nurse oriented across practice settings and manufacturers. A is wrong because brand names do not rotate on a monthly schedule. They remain stable for years until a product is withdrawn or a generic version emerges. So instability is not the reason to prioritize learning generic names. B is wrong because brand names are still widely used in clinical practice, advertising, and many electronic ordering systems. The exam preference for generic names does not mean brand names have disappeared from documentation or verbal communication. D is wrong because color coding is not a regulated feature of generic names. Tablet color varies by manufacturer rather than by chemical identity. So the dependable identifier across products is the printed generic name itself. Every medication has 3 names: a chemical name, a generic name, and a brand name. Understanding the difference and why the generic name is the clinical anchor is essential for safe nursing practice. The chemical name describes the full molecular structure, precise but unwieldy. The generic name, like ibuprofen, is the United States adopted name assigned for international clarity. The brand name, like Advil or Motrin, is a proprietary trademark used for marketing that can change over time. The FDA requires the generic name to appear on every medication label, at least half the size of any brand name. This regulatory rule is what makes the generic name the reliable identifier. Whether a nurse is reading a bottle, a chart, or a medication administration record. Generic names carry built-in patterns. Medications ending in pril are ACE inhibitors. Sartan are angiotensin receptor blockers. Statin are HMG-CoA reductase inhibitors. And Olol are beta blockers. Brand names completely obscure these class-level clues. Brand names are familiar but shift over time and across regions. The generic name is constant across all formulations, all manufacturers, and all countries, making it the foundation for safe medication learning and practice. Question 39. A nurse is reviewing the chart of a client receiving methotrexate for severe rheumatoid arthritis. Which combination of adverse effects would the nurse anticipate during long-term therapy? Your options are: A. Skin pigmentation changes and brittle nails. B. Hepatic fibrosis and bone marrow suppression. C. Cardiac arrhythmia and pulmonary hypertension. D. Cataract development and onset of glaucoma. Don't overthink it. Which one feels right? The correct answer is B. Hepatic fibrosis and bone marrow suppression. B is correct because methotrexate produces hepatic fibrosis, bone marrow suppression, gastrointestinal ulceration, and pneumonitis. Routine monitoring of liver enzymes and complete blood counts guides safe long-term administration, since these toxicities determine whether the medication can be continued at the prescribed dose. A is wrong because skin pigmentation changes and brittle nails are not the primary adverse effects of methotrexate. The hepatic and hematologic profile drives the routine monitoring plan for this disease, modifying anti-hepatic drug rather than integumentary findings. C is wrong because cardiac arrhythmia and pulmonary hypertension belong to monitoring profiles for amiodarone or pulmonary vasodilators. These toxicities do not reflect the hepatic and hematologic risks that define methotrexate surveillance. D is wrong because cataract formation and glaucoma onset are associated with corticosteroids rather than methotrexate. Hepatic, hematologic, and pulmonary toxicities define methotrexate monitoring rather than ocular complications during long-term therapy. Methotrexate is widely used for rheumatoid arthritis, but its long-term, low-dose use carries two toxicities that define how nurses monitor these clients over time. The two toxicities that shape the entire surveillance plan are hepatic fibrosis and bone marrow suppression. Liver function tests and complete blood counts are checked at regular intervals because either can worsen silently before symptoms appear. Methotrexate inhibits dihydrofolate reductase, disrupting DNA synthesis. The liver bears cumulative chemical stress from every weekly dose, while rapidly dividing marrow precursors, red cells, white cells, and platelets are directly vulnerable to the same mechanism. Routine follow-up includes liver function tests every several months, a CBC checked more frequently early on, folic acid supplementation to blunt some toxicity, and close review of alcohol use or hepatitis history, which amplify hepatic risk. When an exam question pairs methotrexate with rheumatoid arthritis, the testing point is always this combination. Alopecia and nausea are real but mild at these doses and do not drive lab monitoring. Hepatic fibrosis and bone marrow suppression do. Question 40. A nurse is teaching a client beginning aminoglycoside therapy about adverse effects to monitor. Which combination should the nurse include? Your options are A. Ototoxicity, renal toxicity, and dysrhythmias. B. Tendon rupture and clinical depression. C. Seizures and hepatotoxicity together. D. Stevens-Johnson syndrome and bone marrow suppression. Got a guess? Lock it in. The correct answer is A. Ototoxicity, renal toxicity, and dysrhythmias. A is correct because aminoglycosides produce ototoxicity, renal toxicity, gastrointestinal irritation, palpitations or dysrhythmias, blood pressure changes, confusion, and hypersensitivity reactions. The nurse teaches the client to report hearing changes, ringing in the ears, or decreased urine output immediately during therapy. B is wrong because tendon rupture is the signature concern of fluoroquinolones, and depression is also noted with that class. Aminoglycoside teaching focuses on hearing, kidney, and rhythm changes rather than musculoskeletal or mood-related effects. C is wrong because seizures and hepatotoxicity are not among the recognized aminoglycoside adverse effects. Seizure risk appears with sulfonamides and hepatotoxicity with other antimicrobial classes, so grouping them with aminoglycoside teaching would misroute surveillance. D is wrong because Stevens-Johnson syndrome and bone marrow suppression are linked to sulfonamides rather than aminoglycosides. Aminoglycoside teaching highlights hearing loss, kidney injury, and dysrhythmias rather than dermatologic or hematologic concerns. Aminoglycosides like gentamicin, tobramycin, amikacin, and streptomycin are effective against gram-negative infections, but they carry a characteristic triad of serious adverse effects that nurses must recognize together. The three hallmark toxicities are ototoxicity, nephrotoxicity, and dysrhythmias. Seeing any one of these in a client on an aminoglycoside should immediately raise suspicion for the others, especially with prolonged or high-dose therapy. In the inner ear, aminoglycosides directly damage hair cells in both the cochlear branch, causing high-frequency hearing loss, and the vestibular branch, causing vertigo and tinnitus. In the kidney, drug accumulation in the proximal tubule injures tubular cells and reduces glomerular filtration rate. The resulting electrolyte disturbances, particularly hyperkalemia and hypomagnesemia, then contribute to cardiac dysrhythmias. Safe aminoglycoside use depends on consistent monitoring. Peak and trough levels guide dosing. Serum creatinine and urine output track renal function. Hearing and balance are assessed clinically or by audiometry, and an ECG is obtained when dysrhythmia risk is elevated. When you see gentamicin or any aminoglycoside on the exam, the testing point is recognition of the full toxicity triad. Ear, kidney, and rhythm problems travel together, and early identification of anyone should prompt assessment of all three. Question 41. A nurse is preparing to administer nebulized ipratropium to a client with chronic obstructive pulmonary disease who reports a known peanut allergy. Which action would the nurse take? Your options are A. Administer the medication at half the prescribed dose. B. Pre-medicate the client with diphenhydramine first. C. Increase the nebulizer flow rate slightly during delivery. D. Hold the dose and notify the prescriber. Which one is it? Pause the video if you need more time. The correct answer is D. Hold the dose and notify the prescriber. D is correct because ipratropium contains soy lecithin and is contraindicated in clients with peanut allergy due to cross-reactivity. The nurse holds the dose and notifies the prescriber, so an alternative bronchodilator without the allergenic excipient can be ordered for this client. A is wrong because halving the dose does not eliminate the allergenic excipient in the formulation. Any amount of soy lecithin can trigger a serious cross-reaction in a peanut allergic client, so dose reduction is not a safe workaround. B is wrong because pre-treatment with an antihistamine does not eliminate the cross-reactivity risk of soy lecithin. Diphenhydramine may mask early reaction signs without preventing anaphylaxis, so the medication itself must be avoided. C is wrong because changing the nebulizer flow rate alters droplet size but does nothing about the allergenic excipient. The contraindicated ingredient remains in every droplet regardless of how the device is configured. Ipratropium bromide is an inhaled anticholinergic bronchodilator used in COPD and asthma. What many nurses don't immediately recognize is that certain formulations contain an inactive ingredient that can be dangerous for clients with peanut or soy allergies. Some ipratropium inhaler formulations contain soy lecithin, a soybean-derived emulsifier. Because soy lecithin shares allergenic proteins with peanut, clients with a documented peanut or soy allergy face a real risk of anaphylaxis, a dangerous complication in someone already experiencing respiratory distress. When a client reports a peanut allergy before receiving ipratropium, the nurse must hold the dose, notify the prescriber, and seek an alternative bronchodilator. Silently skipping the dose is just as unsafe as giving it. The prescriber must know so the client gets an appropriate substitute. The broader principle is that allergy assessment must extend beyond the active ingredient to excipients, preservatives, and emulsifiers. A client who tolerates one inhaler may react to another containing the same active drug if the inactive ingredients differ. Always confirm the specific product when known allergies are present. When exam questions pair ipratropium with a peanut or soy allergy, the correct answer is always hold the dose and notify the prescriber. Never administer and never skip silently. The hold and notify response is exactly what the medication safety system is designed for. Question 42. A nurse is preparing an intravenous medication for a pediatric client. Which rule applies regardless of dose size or clinical urgency? Your options are: A. Push the medication undiluted to ensure rapid effect. B. Skip the saline pre-flush in toddler-age clients. C. All pediatric intravenous medications must be diluted. D. Bypass the infusion pump during medical emergencies. Take a second. Which answer would you pick? The correct answer is C. All pediatric intravenous medications must be diluted. C is correct because all pediatric intravenous medications are diluted before administration because children have narrower safety margins than adults. Concentrated boluses produce dangerous plasma peaks in a smaller body, so dilution is a categorical rule regardless of dose volume or urgency. A is wrong because undiluted intravenous push is forbidden in pediatric administration. Peak concentrations from a concentrated bolus are dangerous in a small body, and speed or convenience does not override the dilution requirement. B is wrong because saline pre-flush and post-flush are required for every intermittent pediatric intravenous dose, including in toddlers. The flush ensures complete medication delivery and clears the line, so no age-based exception exists. D is wrong because infusion pumps are always used for pediatric intravenous medications to ensure accurate rate control. Bypassing the pump removes the safety device that protects against accidental bolus, even in an emergency situation. In pediatric intravenous practice, every medication is diluted. No exceptions for small doses or clinical urgency. This rule exists because children's bodies handle fluid, concentration, and drug delivery very differently from adults. 4 characteristics combine to raise the stakes. Small body weight means even a tiny volume is a large fraction of total circulation. Immature clearance organs cannot process drug loads quickly. Children tolerate osmolarity swings poorly and their veins are fragile. Dilution accomplishes 3 things simultaneously. It lowers the osmolarity at the vein wall, reducing irritation and extravasation risk. It slows drug delivery, giving clearance organs time to respond. And it blunts the acute cardiovascular effects that come with bolus-like concentration hitting a small body. In practice, the dose is reconstituted and further diluted to a standardized concentration matched to the child's weight band. A calibrated pump controls the rate, so total fluid load stays within the child's daily allowance. Even in emergencies, the pump and the dilution are never skipped. The exam trap is assuming a small absolute volume is safe as a direct push. What matters is volume per kilogram. The same small amount is a far larger fraction of a child's circulation. Dilution discipline is the guardrail against translating adult IV practice into pediatric care. Question 43. A client is prescribed both an eye drop and an eye ointment in the same eye at the same scheduled time. Which sequence would the nurse use? Your options are: A. Apply the ointment first, then the drop immediately. B. Apply the drop first, then the ointment after. C. Apply the ointment first, then wait 15 minutes. D. Apply both medications simultaneously into the eye. Before I reveal it, which one do you think is right? The correct answer is B. Apply the drop first, then the ointment after. B is correct because when a drop and an ointment are scheduled together, the nurse instills the drop first, followed by the ointment. The aqueous drop must be deposited before the oily ointment, since drops cannot penetrate through an ointment film into the conjunctival tissue. A is wrong because instilling the ointment first leaves an oily film that blocks drop absorption. The correct sequence places the drop first so the aqueous medication can reach the conjunctiva before the ointment forms a protective layer. C is wrong because waiting 15 minutes does not correct the wrong order, since the ointment film still impairs drop absorption when the drop is added afterward. Spacing applies when two of the same form are used together. D is wrong because simultaneous administration is not feasible. Each preparation requires its own technique and contact time, so a specific order is needed to ensure each form is absorbed without interference from the other. When an eye drop and an eye ointment are prescribed for the same eye at the same time, the sequence always follows a specific physical rule. The drop goes first, and the ointment goes second. An ointment is a greasy semi-solid that forms a barrier over the conjunctival surface. If applied first, it physically blocks the drop from reaching the conjunctival sac, preventing absorption entirely. After instilling the drop, the client waits about 5 minutes before applying the ointment. This interval allows the drop to fully absorb before the ointment coats the surface and seals it in. Anatomically, the conjunctival sac sits between the lower lid and the eye surface. The drop must reach that tissue directly. An ointment ribbon, applied first, creates a lipid barrier that traps any subsequent drop on top, diverting it into the lacrimal duct rather than across the conjunctiva. Drops deliver higher peak concentrations for active treatment, while ointments provide prolonged surface contact for sustained delivery, especially overnight when blinking stops. Together, they offer both the immediate punch and lasting persistence of the medication. Question 44. A new graduate finds an older medication order written in grains and asks the preceptor about the apothecary system. Which response is most accurate? Your options are: A. Apothecary is the preferred system in current practice. B. Grain measurements are required on every medication label. C. All apothecary units have been formally banned. D. Apothecary is uncommon, but is still occasionally encountered. What's your answer? Commit to one before I continue. The correct answer is D. Apothecary is uncommon, but is still occasionally encountered. D is correct because the apothecary system is not commonly used in current practice, but the nurse may still encounter it occasionally with certain older medications. Familiarity with grain measurements prevents hesitation when a legacy order arrives at the bedside. A is wrong because the metric system is the preferred and most commonly used measurement system in clinical practice. Apothecary lingers only in scattered legacy contexts, so calling it preferred would mislead a new graduate. B is wrong because labels are required to display generic names and metric dosing rather than grain measurements. A grain notation on a label is the exception, rather than a uniform requirement in current pharmacy practice. C is wrong because apothecary units have not been formally banned, only relegated to occasional use. The licensure exam does not require apothecary to metric conversion, but calling these units banned overstates the policy. The apothecary system is an older measurement tradition that predates the metric system, yet it still surfaces in clinical practice. In legacy orders, established formulations, and specialty references, understanding it is a patient safety issue, not just a trivia point. The most critical conversion is the grain. 1 grain equals approximately 60 milligrams. Household units follow a similar pattern. A teaspoon is 5 milliliters. A tablespoon is 15 milliliters. And a fluid ounce is 30 milliliters. These come up most in client teaching for liquid over-the-counter medications. Several long-standing medications may still appear in grain-based orders, including aspirin, thyroid extract, phenobarbital, and some historical narcotic orders. Treating a grain value as if it were milligrams creates a potential tenfold dosing error, rekia or koyute, one of the most dangerous conversion mistakes in practice. When a clinician encounters a non-metric order, the safe sequence is to recognize the unit, convert accurately using a reference rather than memory, and verify with a pharmacist before administering. Institutions typically require pharmacist confirmation for any non-metric order, and all documentation should be recorded in metric units. The exam trap is dismissing the apothecary system as fully obsolete. It is uncommon in modern practice, but a clinician who cannot recognize a grain order and respond correctly creates real risk. The correct mindset: rare does not mean gone. Question 45. A nurse is teaching a client receiving a tetracaine topical anesthetic for an eye examination. Which instruction would the nurse provide about post-procedure care? Your options are: A. Rub the affected eye to relieve any residual itching. B. Self-administer the anesthetic at home as needed. C. Wear an eye patch until the blink reflex returns. D. Drive home immediately after the procedure ends. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Wear an eye patch until the blink reflex returns. C is correct because topical eye anesthetics produce temporary loss of the corneal blink reflex, leaving the cornea vulnerable to abrasion and foreign body injury. The nurse provides an eye patch to protect the cornea until sensation and the protective blink reflex return. A is wrong because rubbing the eye while the cornea is anesthetized can cause an abrasion the client cannot feel. The instruction is to avoid touching the eye until the blink, reflex, and corneal sensation return. B is wrong because topical eye anesthetics are not dispensed for home or self-administration. These agents are restricted to supervised clinical use because prolonged application damages the corneal epithelium and can cause permanent visual injury. D is wrong because driving immediately after the procedure is unsafe due to reduced corneal protection and any additional pupillary dilation from pre-procedure medications. The client requires transportation arranged before the examination. Tetracaine is a topical ophthalmic anesthetic that rapidly numbs the eye surface for examinations or minor procedures. Understanding what happens during that numb window and why protection matters but is the core teaching point. Tetracaine works by binding sodium channels in corneal and conjunctival nerve fibers, preventing the influx of sodium ions that would normally generate a pain signal. The result is rapid loss of sensation lasting roughly 15 to 30 minutes per application. While the anesthetic is active, 3 things make the cornea vulnerable. There is no pain signal to warn of injury. The blink reflex does not trigger, and the corneal surface is left exposed to debris, drying, and accidental contact. After the procedure, the eye patch provides a mechanical barrier during the vulnerable window. The client must also avoid rubbing the eye and avoid inserting contact lenses until full sensation has returned. Any new pain, redness, or vision change after the patch is removed should be reported immediately. On the exam, when you see tetracaine or topical ophthalmic anesthetic, the testing point is post-procedure corneal protection. The patch stays on until the blink reflex returns, and topical anesthetics are never sent home with the client. Question for the HESI. A nurse is preparing discharge teaching for a client who sustained a skeletal muscle injury and is receiving baclofen. Which instruction would the nurse include? Your options are: A. Avoid the use of alcohol while on this medication. B. Restrict total fluid intake throughout the day. So, stop the medication if diarrhea develops. D. Notify the prescriber for any episode of fatigue. Which would you go with? Lock it in before the reveal. The correct answer is A. Avoid the use of alcohol while on this medication. A is correct because baclofen is a skeletal muscle relaxant that potentiates central nervous system depression when combined with alcohol. The client should also be cautioned about constipation, urinary retention, and the importance of avoiding other central nervous system depressants during therapy. B is wrong because fluid restriction is not part of baclofen teaching. Constipation and urinary retention are the relevant gastrointestinal and urinary effects. So adequate fluid intake supports the client rather than fluid limitation. C is wrong because constipation rather than diarrhea is associated with baclofen. So the premise of the instruction is inaccurate. Abrupt discontinuation can also cause life-threatening withdrawal effects, particularly with intrathecal pump delivery. D is wrong because fatigue is a common early central nervous system effect of baclofen that typically diminishes over time. Routine fatigue does not require prescriber notification, while alcohol avoidance must be reinforced from the start. Baclofen is a centrally acting skeletal muscle relaxant that works by mimicking GABA at spinal cord receptors, reducing motor neuron firing to relieve spasticity. Understanding its safety profile goes well beyond its muscle relaxing effect. Baclofen binds GABA-B receptors in the spinal cord, hyperpolarizing motor neurons and dampening the exaggerated muscle contraction seen in spasticity from conditions like multiple sclerosis or spinal cord injury. Baclofen itself causes drowsiness, dizziness, and slowed reaction time. When combined with alcohol, opioids, benzodiazepines, or sedating antihistamines, the CNS depression compounds, raising the risk of dangerous sedation, falls, and respiratory depression. Stopping baclofen abruptly, especially after prolonged use, can trigger a dangerous withdrawal syndrome, including rebound spasticity, hallucinations, agitation, and seizures. Doses must be tapered, and clients should never run out of medication without a plan. The two non-negotiable teaching points for baclofen are strict alcohol avoidance due to additive CNS depression and never discontinuing abruptly. Any new medication, prescription or over-the-counter, should be reviewed with the prescriber or pharmacist first. Question 47. A nurse is teaching a client newly prescribed cyclophosphamide. Which statement by the client indicates a need for further teaching? Your options are A. I will notify my doctor if depression or anxiety develops. B. I will take cimetidine with my meals each day. C. My heartburn episodes should decrease if the medication works. D. My warfarin levels will need to be monitored closely. Don't overthink it. Which one feels right? The correct answer is B. I will take cimetidine with my meals each day. B is correct because food reduces the rate of cimetidine absorption, so taking it with meals slows the medication effect. Cimetidine and antacids should be separated by 1 hour, and warfarin levels must be followed because cimetidine inhibits hepatic enzymes and raises anticoagulant exposure. Is wrong because notifying the provider about depression or anxiety is appropriate. Cimetidine crosses the blood-brain barrier and may cause these central nervous system effects. So this statement reflects accurate teaching that does not need correction. C is wrong because expecting heartburn episodes to decrease is correct since cimetidine is an H2 receptor antagonist that suppresses gastric acid secretion. The client has accurately stated the medication's intended therapeutic outcome. D is wrong because monitoring warfarin levels closely is appropriate, since cimetidine inhibits hepatic enzymes and raises anticoagulant levels. The client has identified a real interaction that the nurse should reinforce rather than correct. Cimetidine is a histamine H2 receptor blocker that reduces gastric acid secretion. To use it effectively, timing relative to meals is everything, and understanding why requires a closer look at how gastric acid secretion works. When food enters the stomach, histamine is released and binds to H2 receptors on parietal cells, triggering acid production. Cimetidine works by occupying those receptors before histamine arrives, blocking the acid response at its source. Correct dosing means taking cimetidine about 30 minutes before meals, so the blocker is in place when food stimulates acid. A bedtime dose suppresses overnight secretion, which is when reflux and ulcer pain commonly worsen. Taking it with a meal allows acid production to begin before receptors are blocked, defeating the purpose. Cimetidine also inhibits hepatic cytochrome enzymes, increasing plasma levels of warfarin, phenytoin, theophylline, and certain benzodiazepines. This interaction profile is a key reason famotidine and proton pump inhibitors have largely replaced cimetidine as first-line therapy. Always review a client's full medication list before initiating cimetidine. The classic exam trap is a client who plans to take cimetidine with each meal. It sounds plausible but misses the timing logic entirely. When you see cimetidine and meal timing together on a test, that combination flags a teaching gap the nurse must address. Question 48. A nurse is monitoring a client receiving levothyroxine for hypothyroidism. Which finding is consistent with a side effect of the medication rather than persistent hypothyroidism? Your options are A. Mild heat intolerance and weight loss. B. Resting bradycardia. C. Daily worsening of constipation. D. Cold intolerance with persistent fatigue. Got a guess? Lock it in. The correct answer is A. Mild heat intolerance and weight loss. A is correct because insomnia, weight loss, and mild heat intolerance are recognized side effects of levothyroxine because the medication speeds metabolism. Bradycardia, constipation, and cold intolerance are signs of persistent hypothyroidism rather than adverse responses to the replacement therapy. B is wrong because bradycardia at rest reflects untreated hypothyroidism rather than a levothyroxine side effect. Adequate replacement therapy actually quickens the heart rate, as restored thyroid hormone increases metabolic activity in cardiac tissue. C is wrong because daily worsening constipation reflects slowed metabolism from untreated hypothyroidism, not a levothyroxine side effect. The medication typically speeds bowel function and produces side effects such as diarrhea and weight loss. D is wrong because cold intolerance and fatigue are features of hypothyroidism rather than levothyroxine side effects. Effective replacement produces opposite findings such as heat intolerance and improved energy, rather than persistent cold sensitivity. When levothyroxine dose runs slightly ahead of a client's actual need, it produces a mild hypothyroid picture. Understanding why requires looking at what thyroid hormone actually does at the cellular level. Thyroid hormone upregulates sodium-potassium ATPase across many tissues and increases mitochondrial heat production. At physiologic levels, this maintains normal body temperature and metabolic balance. But at slightly elevated levels, the same mechanism drives excess heat and accelerated catabolism. The overreplacement picture includes heat intolerance, gradual weight loss, and findings like resting tachycardia, tremor, anxiety, and palpitations. Each reflects the same excess thyroid hormone effect viewed through a different organ system. The classic exam trap is confusing the original disease picture with the over-replacement picture. Untreated hypothyroidism produces cold intolerance and weight gain, the exact opposite of what appears when replacement goes slightly too far. When a client on chronic levothyroxine develops heat intolerance and gradual weight loss, The clinical reasoning points to slight over-replacement. The management is a dose review with a TSH measurement, and the symptoms typically resolve once the dose is adjusted. Question 49. A nurse is teaching a client with hyperparathyroidism who has been prescribed alendronate for bone loss. Which instruction reflects proper administration of this medication? Your options are: A. Take the tablet with a bedtime snack while lying down. B. Take the tablet with meals at any chosen time of day. C. Take the tablet whenever it fits into the daily routine. D. Take in the morning on an empty stomach and remain upright. Which one is it? Pause the video if you need more time. The correct answer is D. Take in the morning on an empty stomach and remain upright. D is correct because alendronate is taken first thing in the morning with a full glass of water on an empty stomach. The client must remain sitting or standing upright for at least 30 minutes to prevent esophagitis, the medication's primary concern. A is wrong because taking the tablet with a bedtime snack while lying down increases reflux and esophagitis risk, which is the medication's primary concern. The proper administration is morning, empty stomach, and upright for at least 30 minutes. B is wrong because taking alendronate with meals interferes with absorption and increases reflux risk. The medication must be taken on an empty stomach with a full glass of water and an upright position afterward. C is wrong because choosing any convenient time ignores the strict morning empty stomach rule that protects against esophagitis. The medication has a specific administration window that the client must follow consistently to maintain safety. Alendronate is a bisphosphonate that treats osteoporosis by binding to bone mineral and suppressing osteoclast activity. Its administration protocol exists for two reasons. The drug is poorly absorbed, and it is highly irritating to the esophagus if not handled correctly. Every dose requires three things. Take it on an empty stomach first thing in the morning. Swallow it with a full 8-ounce glass of plain water. And remain upright, standing, sitting, or walking for at least 30 to 60 minutes before eating or taking other medications. Food, calcium, coffee, or juice taken near the dose dramatically reduces how much drug reaches bone. Plain water helps the tablet clear the esophagus quickly and dilutes any residual drug. Reclining traps the tablet against the esophageal lining, which can cause erosions or ulcers over time. When the client swallows the tablet upright with a full glass of water, gravity and fluid volume work together to carry it through the esophagus and into the stomach quickly. Any delay in that transit, from lying down or too little fluid, concentrates the drug on vulnerable mucosal tissue. Remember the integrated logic. The empty stomach maximizes absorption. The plain water protects the esophagus, and the upright position keeps gravity working in the right direction. This three-part routine is the central safety teaching for alendronate and all oral bisphosphonates. Question 50. A nurse is monitoring a client during the first 30 minutes of a rituximab infusion. Which event would the nurse remain most alert for during this period? Your options are: A. Peripheral neuropathy of the extremities. B. Pancreatitis with elevated serum amylase. C. Allergic reaction during the infusion. D. Stevens-Johnson syndrome with skin rash. Take a second. Which answer would you pick? The correct answer is C. Allergic reaction during the infusion. C is correct because monoclonal antibodies such as rituximab, trastuzumab, and bevacizumab carry a risk of allergic reaction during infusion. The nurse stays alert for early signs including chills, dyspnea, urticaria, or hypotension, and is prepared to stop the infusion and deliver emergency support immediately. A is wrong because peripheral neuropathy is the signature of vincristine and stavudine therapy rather than monoclonal antibodies. The priority during a rituximab infusion is hypersensitivity onset rather than peripheral nerve function. B is wrong because pancreatitis with elevated amylase is associated with didenosine and asparaginase therapy. The infusion time risk for monoclonal antibodies centers on allergic reactions rather than pancreatic inflammation. D is wrong because Stevens-Johnson syndrome is associated with sulfonamides and nevirapine rather than monoclonal antibodies. Infusion vigilance targets immediate hypersensitivity onset within minutes rather than the delayed skin reaction pattern of those other agents. Rituximab is a monoclonal antibody targeting CD20 on B lymphocytes. Understanding why the first 30 minutes of an infusion carry the greatest risk requires looking at how the drug interacts with its target cells and what that triggers systemically. When rituximab binds CD20, the targeted B cells release inflammatory mediators, including TNF-alpha and interleukin-6. This cytokine release, combined with possible direct hypersensitivity to the protein itself, drives the infusion reaction. Systemic effects can include fever, chills, hypotension, and bronchospasm. The nurse monitors for flushing or hives on the skin, changes in oxygen saturation, and reports from the client of throat tightness or dizziness, all signs that the reaction is escalating. Pre-medication blunts the initial response, and starting at a slow infusion rate limits the quantity of mediators released at once. If a reaction occurs, the infusion stops immediately and the treatment team responds with epinephrine, antihistamines, and intravenous fluids as needed. The reaction risk is highest during the first infusion when circulating B cells are most abundant. Subsequent infusions are better tolerated after B cell depletion. On the exam, when you see rituximab and infusion reaction, your answer centers on vigilance in that critical opening window.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.